there today. Rohan is there today.
I saw, sir, sorry.
You are the most busiest Mumbai doctor.
No, sir,
We are proud of you.
मम्मी घर पे बैठी है तो मुझे उसके लिए भागना और दौड़ना पड़ रहा है मम्मी के पेशेंट्स के लिए.
Yes, sir, we are live now.
Online?
Yeah.
1, 2, 3, you can tell. Ready when?
Yeah, you can start.
Start. Good afternoon, everybody. We are very happy after the successful program yesterday with good feedbacks. We are going to the second day of PG research webinar. We have lined up 4 excellent faculty today for you. And before starting the program, without delay, I want Alpesh sir, our President Foxy, to address you. Sir.
Thank you very much, Aswat. Very good afternoon to all of you. On behalf of Foxy, once again, I extend a warm welcome to all the eminent faculties, dear coordinators, and teachers, and dear postgraduate students. Yesterday, the part 1 program, webinar 1, was very successful, and as Dr. Aswat has mentioned, we have received many positive feedbacks, many compliments, and many demands for more such type of programs. Those who could not attend the program demanded that please make the video recording and please provide this video recording to us. So I want to inform all those students who could not attend yesterday's program. Once both the webinars will be over, within few days, we are going to upload this video recording on our website. So it will be available to all of you for a long time. We can understand because of this COVID-19 pandemic and heavy workload at your level, some of you may not be able to attend this webinar, but we will try whatever we can do, and we will upload these webinars on our website. So you can once these webinars are over, after that also you can go through this webinar. Today we have 4 eminent faculties and another 4 important topics. Usually I have to attend so many webinars at a time, so once my role is over, I have to rush to some other webinar. But yesterday I attended the full webinar here and I have not gone to other 2 webinars. I have also learned a lot, and I hope you all will learn a lot from today's webinar. Today also I had one more webinar and one Zoom meeting after 4 p.m. So please excuse me, I will have to leave for that. With this, once again, I am thankful to all coordinators, Dr. Aswat, Charmila, Rohan, Niharika, Sunil, Saswat, for this hard work and making this possible. I am thankful to all the teachers for taking these webinars, these informations to their students, for encouraging them to attend this webinar. And I request all those postgraduate students and teachers to spread this message to more and more postgraduate students to enroll in Foxy's PG Forum. There are so many other programs in line, and you all will be very happy to attend all those programs. Thank you very much. Once again, I wish grand success and happy learning to all of you. I wish all of you safety. Thank you very much. With this, I hand over mic to Aswat.
Thank you, sir. Thank you so much, actually. So it's all your vision. Students should understand that all the vision and ideas of Alpesh sir, our president, is what we are all doing. So all instructions are given by sir. We are all carrying out all these things, and I'm so happy to work under sir. He gives us full freedom to work. By way he tells that you want this program means you can get anything, full freedom. That is what we are all happy with. All our PG forum, be 4 people and 5 people are doing it. So we will be expecting you, everybody who are listening. There is a paper poster competition coming. Your brochure, the flyer has come, and in that email IDs are there to submit the abstract of the paper, and poster you can submit it as such. Rest in the detailed brochure will be released in 2 days. That will come to you by email. Okay. So without wasting time, I have sir.
Before we receive the final brochure, let me inform all of you that 5th October is the last date to submit the papers and posters, and this conference will be organized on 10th October from morning to evening, exclusively for only postgraduate students, exclusively only for the to present papers and posters. There will be no talks, no panels, nothing. So please take benefit of it. But if you receive the brochure or any information late, then also let me inform all of you that 5th October is the last date. So please start making papers and posters from today itself. Thank you.
Thank you, sir. I had sent the initial flyer to everybody so that they have started receiving posters and papers. So, sir, it will be out of control. What we expect, I think that it will be much more that we will think about it, how to channelize all these things today itself. Okay, anyway, without wasting time, today we have 2 more coordinators. Today you would have seen yesterday Dr. Chamala and Dr. Shashwat. Today you will see Dr. Rohan and Dr. Nikhariga when the time comes, and Charmala has already joined along with us, and thanks to her. Dr. Rohan will be the first moderator for the first 2 sessions. Dr. Rohan, as you know, he is the associate professor in D.Y. Patil Medical College. More than that, he is a very active member of AMOX as well as Foxy. So he is into, and he has received so many awards, and you may all as students, you would have seen he is a son of last year President Dr. Nandita Palshetkar. So everything, he has a gene for all these things in him. So he will be moderating today.
Aswath, in one sentence, he is a multi-talented personality.
He's a dancer, singer, everything. So you will see him afterwards when you in the conferences. Now today, this time he just lost chance for all the other activities because conferences are not there. Otherwise, I would not have introduced him. You would have known him better. Okay. Anyway, without much introduction, Rohan, the mic is yours. You can introduce the first speaker and carry on with the program.
Thank you so much, Alpesh sir. Thank you so much, Ashwath sir, for giving me this opportunity to be a part of this PG Webinar Research Forum. Without taking too much time, I would like to start introducing the first speaker. Could we have the slide, please? I think we have this. So our first speaker is Dr. Sarita Agarwal. She's the professor and head of obstetrics and gynac and associate dean of AIIMS Raipur. She's also been the vice president Foxy, ICOG governing council member, chairperson of the HIV committee of Foxy. She has organized many conferences and CMEs, as you can see. The awards and prizes go on. She has also been an invited faculty for international conferences, and she's also been the chairperson, Institute of the Thesis Committee, chairperson of the Hospital Patient and Quality Improvement of AIIMS as well. So, ma'am, handing over to you, I would like you to please begin your program. Ma'am, your mic is muted.
Sarita madam, your mic is muted. Sarita madam, mic muted. Unmute yourself, Sarita madam.
Yeah, I unmuted.
Yeah, very good. Madam, keep it in the slideshow, full slideshow. Okay, madam, start.
At the outset, I'm thankful to Dr. Alpesh sir and Ashwath sir for giving me this opportunity, and Dr. Rohan for his kind words. And welcome all the PGs being the opening batsmen for today's webinar. Let's discuss about that. My topic for today is importance of writing case paper, registry, and record keeping. You know, everybody think it is so simple. Why we are taking this topic? We are doing in the day-to-day activity, but definitely there are certain intricacies for which this topic is being allotted for discussing amongst the postgraduate residents, because we are just joining the PG courses and we are with the paper work, and then we just feel that it is not good for us. Therefore, certain learning outcome, which will be the part of my lecture today. The first, why to maintain the patient medical record, what the medical records comprises of all the documents, then identifying the 6 C's of charting in the case record, understanding the LCOP standards in writing a case paper, and illustrating the correct procedure for correcting and updating if some mistake has happened when you are writing on the case paper. Then coming to the medical record keeping, what are the SOMR, POMR, and the SOAP format for keeping the medical record, and how to release the medical records, when to release the medical records, and how long we need to preserve the medical records, what are the importance of national registry, and of course, few words about the medical audit. So let me just start with this, why documentation is necessary. We all know the spoken word flies away, but the written words remain. And if the procedure is not documented on the case sheet, it is considered it is not being done. Therefore, the medical records are the clinical written records, which is an integral component for delivery of each healthcare setups. It may be a private, it may be a government, but the record keeping makes a very important domain in all the clinical graduates. So what we know, we are just doing day-to-day OPD records, admission case record, the consent forms, the operation notes, the investigation reports, the discharge referral slip, and the death summary. These all constitutes the medical record, and what we have to do in this medical record, I'm going to just tell you in brief. You know, case paper writing, the first year PG is overburdened and think it is a Herculean task. Every time thinks I am a clerk. It is unfair on my part that I have to write so many things on the case paper. But my dear friends, writing is very important. Why the case paper should be written with perfection and why it should be a good documentation. Let me give some examples. Just think about a 25 years, 34 weeks pregnancy presented at 10 p.m. in the night with a swelling in the leg. She has moderate anemia. BP was normal at the time of admission. She was attended by PGJR1, informed to the PGJR3. She advised admit her and do the workup for anemia and pregnancy-induced hypertension. She was admitted, all the investigations sent, and the routine treatment like iron and calcium started, awaiting the investigation. But what? In the next morning, she developed convulsions. On catheterization, the urine output is nil, and she was delivered by the emergency cesarean section, but the baby was unfortunately intrauterine death. And the catastrophe was she was having the acute renal failure and the patient could not be saved. So can you just guess what we missed, where we went wrong? See, look at in this. The PGJR1 failed to document the referral slip. This patient was referred as a known pregnancy-induced hypertension. She was on low bed 200 mg BD, Nicardia 10 mg BD, and she had no urine output last 4 hours. And hence she was referred. But neither the PGJR1 nor the PGJR2 looked into this referral slip, and because of that, the overnight all antihypertensive is stopped, urine output being not monitored, and she went up in the irreversible renal failure. We lost this patient. Therefore, my dear friends, documentation helps in good clinical care. If you document what the referral slip is there, if you document a good clinical history, it will definitely going to help to provide a good clinical care to the patient. Let's see the second example. You are in the clinical rounds with the consultants, 32-year primary with fetal growth restriction. You are told about everything about the history of the patient and the clinical findings. Suddenly the consultant says, tell me the previous USG findings of the Doppler reports. I just want to compare and then decide the management. What happened? You just searched in the case ticket here and there. There was no documentation of the previous USG finding. The junior did not record on the case sheet. And when you're looking for the relative which were carrying the report is just out of the hospital. And you're not able to get her report. So, my dear friends, again, documentation helps in dissemination of information between the members when your a multi-professional team is working. So, documentation again become important. Coming to the third case, you want to do a research project. Your thesis guide or your project guide has allotted to do a retrospective analysis to determine the incidence, clinical feature, risk factor, and outcome and ectopic pregnancy. You did all preparation, all summary proposal has been written. Now you are going to look for the case record sheets. And looking at the case record sheet, you want to look at etiological factors or do not find a data on the PID, STD, infertility treatment, etc. Then how you can find out the etiology. Similarly, certain clinical features may not have been written correctly. And here you meet in the retrospective analysis is not possible. Coming to the prospective study, see, most of the time we design a prospective study. Of course, most of the time we individually may not be present. Therefore, you prepare a case sheet, you prepare a case record pro forma, and that you keep in the hospital, and this has to be filled up by whosoever the physicians attending, and then of course you are just going and looking into that. But what happens many a times, you just go back and look at the case record sheet and you don't find your data, and then you are lost. So your thesis may not be completed, your research project may not be completed. So again, the proper documentation helps in research, whether it is a prospective research or it is a retrospective analysis. Now the most important, for which everybody feared it, about the medical legal proceedings. If you look at certain case scenarios in the court, that Kanhaiyalal Ramlal Trivedi versus Satyanarayan Vishwakarma, here the doctor was guilty because for the deficiency in services, because the case record could not prove that the evidence standard of care was being provided to her in the hospital. Another case, Force versus Mr. Ganeshwara Rao in 1998, the State Commission held that there was negligence as the case sheet did not contain a proper history of the treatment, recording of the investigation, even the consent paper on the case ticket was missing, and the doctor has to pay the penalty for the same. Similarly, if you look at another case, Anjani Kumar versus Madras Medical Mission, the allegation was that the patient party were not informed about the vocal cord palsy risk during the surgery. But when the case record was looked for, a detailed written consent that showed that it was explained properly and consented, and the doctor was saved from this because the proper documentations were there. So again, my dear friends, documentation helps to address the complaints or the legal processes, and it can save you from the various medical legal points. So just in summary, again, just to have a recap, record keeping makes the continuity of care easier and better. Record keeping helps in communication and dissemination of information between the different members of the hospital and the healthcare workers. Record keeping helps to address the complaints on the legal processes, and the good record keeping supports the clinical research audit. Apart from this, there are certain other advantages. Look at this. Patient education. You all know, looking at the case record, you can just explain the patients, these are the problem, and based upon that, you need this instruction to be followed up. Medical education. I think every PG is daily presenting one other case in their academic classes, and these case sheets makes you to learn more and more. If improperly documented case sheets are there, you may not be able to define your agendas when you are presenting a case in the academic class. Further, another important point is that the most of the epidemiological study which decides where the funds to be located, what are the priorities, and based upon this epidemiological research only, it helps where the resources should be allocated and how the planning should be carried out in the healthcare program to improve the overall status of the country or the states. And further, we know we are dependent upon many guidelines. We look at the peer reviews, we look for the healthcare analysis and all. So these are also again based upon the good clinical case recording on your case sheets. So now we understood, yes, the case record keeping is very important. Then now the question comes, what you have to do on the case record, what are the things you have to look for, and what are the contents, and how to write a medical record. So just talking about something, so this is very common on our past. We look in the case record sheet or the admission ticket, the first part is the patient registration form. The second part is the patient medical history, which includes the chief complaint, present illness, treatment history, past medical, surgical, family history, social history. I think we are taught about a lot in our undergraduate teaching also and in the postgraduate teaching also. Then we go for the physical examinations, the investigations, and then the doctor's diagnosis and the treatment plan. I'm just scrolling down it fast because I'm just going to point out. We are doing it day to day, but definitely we do some mistake and then we have the regret at the end of the day. So I'm just going to point out what are the common mistakes are being made in the case record registries. The patient registration form, we forget to write an emergency contact number. So if the patient lands up in certain emergency, you want to inform and talk to some of the relative, you just miss that and you may not be able to inform. Similarly, we just forget to write the insurance and the financial information. This when the patient party wants to claim for it, then you may be stuck up that you may not be able to find out which patient is registered under the financial or the insurance schemes. If you look at the past medical history, then what is important in the past medical history? We take lots of history, we may not be relevant. For example, if you are taking a case of anemia, then you need to look for the past medical history and the part that whether she was having the history of blood transfusion or she had some bleeding disorders or she has the bleeding piles or the gums. But these relevant history may not be relevant in case of the pregnancy-induced hypertension. So that's why the previous treatment history is the past history is very important in the patient. And then coming to the previous treatment history, most of the time we forget. As I discussed in the previous case, the pregnancy-induced hypertension, patient was on antihypertensive and we missed the right out in the document. So sometimes it happens, most of the cases of infertility patient, when it comes to us, then the same treatment may you start it and the repetition of treatment and you don't get any results. Therefore, the treatment history is important. Further, if the patient is on certain medication, the drug interaction needs to be noted before prescribing any medication. Same for the past history I already discussed. Then for the family history, again, like the history of thrombophilias may be important in the board obstetric history and PIH, but it is not important in case of anemia. So whenever you are taking the history, it is very important that the history which is noted down should be relevant to the case. There is no means of writing unnecessary things on the case records. Then most commonly we miss the history of allergy or the drug intoxication, and then you give the medicine and the patient can face the catastrophe when you're managing the patient. Physical examination we most of the time write because we have our own hospital standard protocols. But what we missed in the investigation, we failed to document the previous investigation of the patient. So it is very important the patient gives you the previous investigation. It should be noted in the case record sheet. Why it is important? Because most of the time it happens when we discharge the patient, we return back this investigation papers to the patient. And then suppose that after years together some medical legal case comes to you, then you just don't find all this investigation and you fail to produce that previous statement of what investigation was there and why the patient is being referred to you. And then whenever you're compiling the investigation, it should be the reverse chronological order. That means the most recent investigation should be on the topmost part of your case sheet. Then if you are calling some consultants or you're taking opinion of some super specialist, in such cases, most of the time we just have a talk on the phone, telephonic consultation. And now in the COVID pandemic area, most of the consultation is going on the phone. Therefore, it is very important if you are taking a telephonic consultation, it needs to be mentioned on the case record sheet that the patient consulted on the phone and this must be advised by the next consultant. Then what we miss? Operation details. When we write on the operation, we just write the routine, what we do, the surgery and how it is done. But it is very important if you find some difficulty, suppose there are the intraoperative adhesions are there, suppose there is a bowel injury or there is some bladder injury, it needs to be documented. And at the same time, if the specialist consultant has been invited for the assisting in the surgery, that needs to be mentioned because it is very important. See the mistakes or the injuries are likely to happen in surgery, but if identified it on table and the concerned consultant especially being invited and that was take care of this, then you are not liable in the court of the law. So if at all, don't be apprehensive in documenting if there's some mishap happen in the OT. It should be very well documented in the case record sheet. Similarly, if there's any adverse drug reaction to any of the drug, it should be mentioned and should positively be mentioned on the discharge ticket with the board letter that patient has allergy or the drug reaction to this drug. Coming to the consent form, we know we do have the different type of consent form. Most of the time we do have the printed consent form, and then we use the same consent form for all the conditions. Again, I just want to tell all the postgraduate students, when you are taking the consent form, don't forget to mention the IPD number, don't forget to mention the name and the what is the diagnosis and what is the surgery plan or what are the treatment plan for that. And then each line, this consent may be different for different type of cases. So of course we do have the printed form to save the time that you can have this printed format with you, but along with that, if you are taking certain special consent, then a documented handwritten consent stands a lot, and this consent may be preferably to be written by the patient relative or the patient herself, and then it should be properly explaining informed consent, by which we mean it should tell everything about the what this procedure you're going to perform, what are the drawbacks which can happen and how it can help, and what are the other alternatives, protocols for the management, and that everything, if it is explained very well in the consent, in the handwritten, in the patient's own language, and then at the end signed by the person by the patient. If it is more than 18, it is must, and one of the patient's relative, and then the person who is taking the consent, and if at all possible, you can take one witness signature also. So you can see these columns in the lower part, which is very clearly mentioned. Now what happens most of the time when we take the consent, मैं मेरे मरीज का ऑपरेशन कराने के लिए तैयार हूँ, and at the end the patient, whoever is there, his signs and the relation is not being mentioned. So it is always better when you are taking a consent form, you have to write like मैं मेरी बेटी और मैं मेरे बेटे का सर्जरी कराने के लिए तैयार हूँ. So that itself tells that he is the son of or the daughter of that patient. The son or the patient is the son or the daughter of the person who is consenting for it, and then you are very easily able to recognize who has consented. See, we have certain cases where someone else has been signed who are not related, and then you face the problem that this consent was not given by patient's relative. So consent makes very important that informed consent should be documented. So this is all what I had talked about the consent. Then another part is that if the patient is not compliant, that you are asking for some treatment to be given to the patient, or you are advising for certain investigation, or you are telling some instructions to follow, but the patient is not following that, then it is always better to document on the case paper that the patient is being advised and this patient is not and refuse for this treatment at all. Most of the time it happens, suppose you decide for the cesarean section, a patient says, no, I don't want to get the cesarean section done, I still want to wait. And suppose it happens, you had taken all your decision, then only you allow that you still feel that cesarean section should be done, but the relatives are not giving consent, you can't operate upon the patient. So in such condition, it's always better that you should document it that the patient is not willing for this, and all the risks are being explained to the patient or the patient relatives. So these are the important part of the consent. Then there are certain things which we usually and the most frequently miss. Is a missing name and the IPD number in each page of the progress sheet. It is very important because if one of the progress sheet is being missed, you may not be able to look for what problem, how the patient is being managed in the hospital. Missing dates and time. Most of the time we write the dates, but we just forget to write the time whenever you are putting the notes. It's, my dear friends, you should always mention what is the time also. And it should be written so clearly that it should be legible, readable by all. We are in hurry, I know, but it doesn't mean that in hurry you should not make the documents very clear. Then missing signature and designation. Most of the junior doctors, they just they forget to write. They don't put their signatures. So postgraduate they are very well authorized to make the notes, to prescribe the medicine, and then they have to sign. And of course, if something is being discussed with some consultant or the senior person, you need to mention that advised by so and so, and then you sign it. So at the end, you should always sign and write your designation, your PGGR1, PGGR2. Then he has seen the non-standard abbreviations are being written. IVO, then we don't know what is that, then we know the in view of. So there are certain non-standard abbreviations should not be used. Those abbreviations which are very commonly used in the medical terminology and understandable, like an IV, IM, SC, subcutaneous, like this, the common abbreviations and which is understandable by all should be used. Then when you have certain mistakes, we do the whiteouts or we do the scribbling that nobody should be able to read it. But this is not the way. I will be just describing how to correct your mistake if something happens in the case record sheet. Then whenever you have to write the history, you have to write the history of present illness, history of past illness. Whenever it is described a descriptive one, please don't forget to mention a descriptive one. Otherwise, many of the places, they just have the checklist. Of course, the checklists are good, but if you need an elaborate history or the elaborate treatment plan, it needs to be written very well. So just to summarize what I had discussed in 7 and 8 slides, the documentation practice 1, you all must know the 6 C's of charting. What are these 6 C's? It should be in the client's word. It should be in the chronological order. It should be written with the clarity so everyone can read it. It should be concise and to the point. Don't write unnecessary things which are not relevant to your case. Then it should be a complete. There should not be incompleteness. And don't forget that the patient record is a confidential thing. It should be maintained with the confidentiality, should not be discussed, should not be gossips if some patient has certain problem, and should be very clearly written. So these are the 6 C's. Then coming to the documentation practice 2, that is the ALCOP protocol or the ALCOP standard, which is considered this attributable, legible, contemporaneous, original, accurate, and the professional attitudinal tone. So let me describe each of them one by one. What do you mean by attributable? It should be relevant and it should be reflecting what you want to write and what you want to communicate to others, and there should not be any misunderstanding. Should be reflected by what you write on the paper. I had described it should be legible, that everybody can read it. Contemporaneous, that means it should be the time frame, all the time should be written. It should be one by one. It's not like that 10 a.m. notes is written after 7 a.m. note. It should not be like the 10 p.m. notes is written after 7 p.m. 12 midnight notes. Most of the time I have seen, I don't know why the AM and PM ka chakkar, our students don't understand. Sometimes they write AM, sometimes they write PM, and still getting lots of confusion. So please just check that the time is very, very important. It should be on the chronological order. And if there are any delay on making the notes, sometimes it happens you're busy in emergency, you may not be able to make the note at the same time. Then you may be able to just write the acceptable delays, and which is defined and justified looking at your notes and the clinical care provided by you. Then whatever you're writing in the case paper should be original. Never guess and never assume. What the patient says you write, what the consultant says you write. Never guess that this may be like this or this may be like this. So assumption is not permitted when you're writing on the case paper. Everything what you write is to be original. Accurate means you need to write it accurately. Especially it happens when you're writing the investigation reports, which is microliter or it is a nanoliter, something like, the unit writing is very confusing. And then it is very important when you're writing the investigation, the values, you should double check the accuracy of the findings, what you have written is accurate. And similarly for all other investigation finding, when you're writing, the clear instruction should be there. Then what we mean by the professional attitude and tone? See, that means Do not record the personal or the subjective comments. Don't write the speculation. It happens sometimes we just try to call some person and the person does not pick up the call. And then sometimes we have seen that it is being mentioned in the case record form, so and so has been trying calling but could not be contacted. This should not be written. Or sometimes we write that this patient could have been managed like this, but it has been managed in other ways. So this type thing should not be written on the case sheet. Of course, if you have some queries, it should be better discussed with your colleagues, and then you record on the case sheet what is relevant to the case sheet, and that show your professional attitude and tone on all the case sheets. So just a question. What is why it is important, and what are the things you must remember when you're documenting in the medical records? Just to have a recap, documentation practice 1, the 6 C's of the charting must be remembered, and the source documentation standards, that is the ALCOP, should be very well understood. I'm just repeating again because it's very important. 6 C's stand for the client's first, chronological order, clarity, consciousness, completeness, and confidentiality. And ALCOP standards stand for attributable, legible, contemporaneous, original, accurate, and a professional attitude and the tone. Now coming to how to correct a mistake on the case sheet, if at all is there, if there's some error. Look at this AROR, you have written the wrong mistake. How to correct this? You simply draw a line and the original information. So the whatever you have cut is still visible and legible. And then insert the correct answer, that ERROR, and then document why the correction was made and at what time the correction is being made, and then you have to sign it there. That is very important. Sometimes it happens, suppose I have written an amoxicillin capsule 500 milligram thrice a day, but my next consultant comes and says, no, there's no need of amoxicillin. Maybe you have to just write it, maybe the cephalosporin to be started. Then you cut amoxicillin there and write the date and the time, and then write the next prescription. That is the prescribed is the cephalosporin 500 mg TDS. So in this way, whatever you cut should be still visible and it should be justified why it has been done. Date, time, and initials at the time of correction should be made. And if possible, if fitness is there, major things are being corrected, something's happened, the consent, then at times the witness should also be there and their signature should be taken. See here you can look how the correction is being made. My cursor, yes. See, if it is written N and you want to correct it by Y, then single line and then write Y, and then here the date and time and the signature is there. And here if you the incorrect method, you can see it has been just obliterated by another pen. It should not be practiced. Then here the overwriting is there. This overwriting is again not permitted when you are doing the case record. So this one is about the how to fill up the case record sheet. Then we know that we have a medical record keeping system, which is very, very important. It is now alive for all of us because most of the patient are the chronic patient. They're coming to us repeatedly, and then we have to look into the medical record. So whatever you are documented at the time of admission, even the OPD card of the patient has to be kept, and whatever you have done, the case sheet, the consent form, the admission ticket, the discharge ticket, the reference slip, they all are kept in the medical record department of each of the hospital. Now, there are so many records, they can be piling up the records if you are not keeping it and organize it properly. Therefore, there are the system for the medical record keeping also. It can be in handwritten record, it can be a computerized record, and along with the handwritten and the computerized report, sometimes you need to store the imaging films, photographs, videos of like laparoscopic surgeries, and the printout from the monitoring equipment. It is very important. Most of the time you preserve the printout of the this anesthesia monitors when you're doing a surgery. And if there's any correspondence with the health professional, like with the fax and the email, they all has to be combined in the medical record keeping system. Now, if you look at the simply keeping the hard copies of the record, and when you're keeping it in the computerized, I think well understood by all of us that the electronic medical record makes the life easy as it requires less space. It is easily available. You can apply different filters if you want to get certain information, and then you can get it immediately available. Fire safety is there, and if you want to transfer the document from one place to other place, it can be easily transferred. But there are of course certain disadvantages, because the medical record keeping, this electronic medical record keeping, requires the retranslation of the information, and then you need a special medical record keeping personnel to keep it, and sometimes it can be stolen or hacked also. So the safety of this record keeping is very, very important, and it has to be preserved for the longer time. I will be discussing how long the medical record to be preserved. So there are different format of medical record keeping. One is a SOMR, that is a source oriented medical records. That means here we keep the records from where it has been received. That is the hospital, from the labs, from the from the radiography, or from the imaging system. So you record the patient case record first, then you record the lab reports, then you preserve the other investigation like the imaging. So it is a source oriented medical records. A disadvantage of here in the source oriented, that you don't have the continuity of the record. If you want to look at the case history and you want to correlate with the investigation, these things are not available. So SOMR has its own problem, but it is easier to record. And sometimes if you want to look at the progress in the ultrasound, you can just go on one by one and you can see. So there the grouping of the medical record is there when you're doing the source oriented medical record system. Next is the problem-oriented medical record system. Here, each problem is numbered. We first find the signs, symptoms, then the patient's progress report, the treatment, the diagnostic, and everything in one by one. So the continuity of the record is there. So the example of the problem-oriented medical record is understood with the SOAP documentation. What we mean by SOAP, in the SOAP documentation, S stands for the subjective data. You first mention the subjective data, that is what the patient tells you, that is the history part. Then you have the objective data, that is what the doctor or the healthcare provider elicits, that is the examination findings. And then next is the assessment, diagnosis based upon the investigation, and then the history, what assessment is being planned, and then the plan of management. So based upon history, investigation, and assessment, you plan what management has to be given, and the management, next comes the what management is being given. This SOAP assessment is there. So you have first subjective data, then you have the objective data, then you have the diagnosis, assessment, investigation, and then you have your treatment plan and the treatment given. The next of this is some example. I'm just keeping this slide. What is subjective? What is objective? We know the patient complaints like headache, chest pain, poor appetite as a subjective, while the skin color, pulse, and the respiratory rate is objective records. Then expansion of the SOAP format is CHEDDAR, which is exactly the same thing. It has been described in this other way. C for the chief complaint, H for the history, E for the examination, D for the diagnostic test, and another D for the drugs and doses, and A for the assessment of the diagnostic process and treatment plan, and R stands for the written visit information, the referral. So this is same thing like SOAP format, but it has been more elaborated and has a more bifurcations. Ultimately, the pattern is exactly same. That is a problem-oriented medical record. So I think you might have understood about that. What are the different format of the medical record keeping? Now I'm coming to responding to the release of the record request. Sometimes the patient party wants a certain records to be released. So for that, what are the records which can be released and what are the records which cannot be released? Just to have one slide on that. There are the different categories of the medical record. The first record given to the patient as a matter of the right, I think we all know that the discharge summary, the referral notes, the death summary, and the patient's own investigation which has been done. We give this all to all the patient. There's no problem in giving this, which are the part of the patient's right. The second type of record are the record issued after the patient or the authorized attendant fulfills the due requirement as stipulated by the hospital. That means these are the records which are not being given to the patient until unless a special request being submitted by the patient, and the purpose of that should be there. These are the copies of the inpatient files, the records of the diagnostic tests from your own hospital, the operation notes, the videos, the medical certificates, and the duplicate copies for the lost document. These are the records which can be given only when the patient makes you a special request. Then the third type of record, the records that cannot be given to the patient without the direction of the court, means can never be given to the patient itself until unless it is being asked by the court of the law. So these are the original outpatient file or the original inpatient file. The original document should never be handed over to the patient or the patient relative or anyone else until unless it has been asked by the court. And then if any of the medical legal case is under the process, no document of such to be given to anyone until the case court orders for it. So I think it's very clear when you can hand over the records. So this is again very important. Our postgraduates are very simple. When the patient come and they ask for something, they just allow them to take this away. But should not be the practice. You should understand which can be given and which cannot be given to the patient. Now just a quiz. You receive a phone call from another hospital that transfer the medical record of the patient. That patient was admitted in your office and I need this. Are you going to provide the information to the next physician on the phone call? Answer is no. You cannot. You never release the information based on the telephonic authorization because you are not sure who is calling. So it should be always a written information. On the written request only you can release any of the record of the patient. Then coming to the last slide of the discussion, how long should the medical record be preserved? As per the different acts, that is under the provision of the Limitation Act 1963, Section 24A of the Consumer Protection Act and the Medical Council of India guidelines, all the outpatient records should be kept for the 2 years and the inpatient records should be kept for minimum of 3 years. And if it is in a pediatric case, you know that in the pediatric case, till the person becomes a major, he can still file a case. Therefore, in the pediatric case file to be kept for the longer time, that is till the patient becomes the major, and maybe for 3 years after the achieving the age of the majority. The pediatric case record is very important. I still remember one of the case when the baby was delivered in some of the private hospital, and then he became the person who joined in the US, and then they noticed that the facial palsy is there, and this facial palsy was documented because of the forceps delivery. And then we looked for the record of this patient was not there in the hospital, and then the doctor has to pay a lot for this. Therefore, then the pediatric patient, the record has to be kept till he become the major. And if the medical legal case is ongoing and any of the case, the file should be kept till the final disposal of the case. Even if you receive a single notice, it has to be kept for till the medical legal case is being disposed of. About the auditing, I think no need to go in detail. We have the internal audit, which is done by the medical staff of the hospital itself. Then we have the external audit, which is done by the government entities to look for the standard of care being provided by the hospital or not. So to summarize, medical record, a very important document, should be maintained very properly with the chronological history, treatment plan, observation, opinion, and the investigation. It is very important not only for the care providing, but also for the research tool, education, and decide the policy priorities. Then the 6 C's of the charting are the patient's clinical, client's word, clarity, completeness, consciousness, chronological order, and confidentially. ALCOP standards: achievable, legible, concise, accurate, professional attitude, and tone. And the proper way of correction is draw a single line. It should not be obliterating. Records are always confidential. preserve the record for OPD 2 years, for IPD 3 years, for pediatric till the attain the major, and the medical legal till the disposal of the final medical legal case. So I thank you for all for the patient listening. I know I went uninterrupted without any break because I could not see anyone who at all are listening. I could not see the expressions also to give the pause or not to give the pause. But I feel at the end the documentation done is properly, so no one has a regret. And I regret for nothing. That should be the end when you do your job as a record keeping. Thank you very much.
That was
Excellent,
very
madam.
comprehensive, ma'am. Excellent it was. And I don't think people have any doubts regarding documentation now.
Madam, you can
There are
stop
not much-
sharing, so we will see
Yes,
everybody.
yes.
There are not much of questions on this particular topic. I think they'll come at the end of the next talk. But I have one or two questions, ma'am. Dr. Sarita, ma'am. Shall I
Yes,
ask?
please. Yeah.
Suppose you want to do a retrospective analysis of your patients and you're taking out documents from the previous records. And how do you get a consent from such patients who are not in the hospital at that point?
For the retrospective getting the documents, I think the patient consent is not required. Whatever documents in the hospital is there, you need to get the permission from the medical superintendent. And once the medical superintendent gives you the permission, the medical record officer can provide you the documents. But of course, the original record cannot be taken away by you. You need to sit in the MRD and there only you can write whatever you are needing for the research. The tickets cannot be provided to you. And such cases, patient. In such cases, patient. No, in that case, the patient's consent is not mandatory.
And suppose it's an improper documentation, who will be responsible for that?
If the improper document, of course, the treating consultant is responsible for everything.
So that's why they're very
Actually, if it is a resident, it is ultimately on the unit head followed by the HOD. It is more like that,
Yes.
no? Because, so it may not be necessarily the resident only.
For the major mistake, they can come as a part of the vicarious responsibility, but the also responsibility of the treating doctor. So I think we should not disseminate this. The PGs have to learn. They are going to be the consultants in
Absolutely.
future.
Yeah. And
They are
then
going to-
it doesn't absolve them of their omission. Omission is also considered by law.
Yes.
It's a penalizable offense. So it is not a good idea to do that.
And another thing, the day-to-day activity, in the day-to-day activity, their internal assessment is being done. If the resident is not doing their job properly, they may lose their internal assessment marks and may not be good on their final results also.
Okay. Ma'am, there's one question from Kodi Prabha Devi, and she's asking, is it original reports or Xerox copies which should be placed in the patient's register? That is the OP original or photocopies to be kept?
Photocopies, whatever the patient brings from the outside, their photocopies has to be kept because that is the patient's property. But whatever the investigation done in your hospital, it is better to keep the original copies in the case records.
Another question which is asked is that if you want to study medico-legal cases, is there any special permission needed? Like, for example, studying suicides in pregnancy or something like that, where patient maternal mortality, medico-legal cases.
Yeah. On such, again, it is because these are the confidential system, the hospital, there are two things, medico-legal cases ongoing on certain case, or we just want to record a maternal mortality statistics. So if you want to have a retrospective analysis of maternal mortality statistics on such cases, of course, you're going to get the approval from your institute review board. And once you get the review board permission, then you have the permission to publish that data on whatever journal you want. But if some medical legal case is ongoing on certain, case, on such cases, ideally no retrospective data or nothing is being provided to the person, and ideally this type of situation should be avoided.
And one more thing, the patient starts taking nowadays photos of the case sheet with the mobiles. Anything is that even if we are not giving, many times they will come and, is this in the court that stands?
I think I am not that much of the expert, but what I feel, these copies will not be an authenticated copy, because whenever the patient asks, we have to provide the photocopy which is duly signed by the treating physician as well as the MRD section, and which only stands in the court of the law. Whatever is being taken in the mobile phone, that is not, as per my knowledge, it is not acceptable in the court of the law.
There is another question which has come. If there is any intraoperative surgical complication, how long the record should be kept?
Whenever as per the rules, they say it is for the 3 years for all the indoor records are there. But something, most of the cases, if some medical suits have to be followed, then they are being done on that time. But ideally, looking into our circumstances, we are all keeping our records at least for the 7 years, though it will not be mentioned in the MCI or the other rulings and all. Just to avoid the medical legal safety on our part that we should not miss.
Would you give the record laparoscopy or surgical recordings to the patient? It's a must if they ask for.
Yeah,
recordings.
Recordings can be given.
And
yes.
Recordings, if they ask for, it has to be given.
It can be given.
It's not compulsory, I think.
It's not compulsory.
Choice of the surgeon.
It's choice of the surgeon, but usually, but most of the cases, I think everybody is giving the surgical records to the patient. Even the CT scan and MRI, they are giving the films of that on the CD. So that is not at all a problem.
But when you're giving a video recording, you have to be extremely careful. Sometimes you can land up with problems because they can say that this is not the way to do, that is the better way to do and all that. So it's
I have a suggestion there. I have a suggestion there. You may not give it right there and then. No? You can engage the patient. You take time, edit it. But then also then the questions arise whether edited one is acceptable. So
it's better not to give video recordings at any point, because they can change the recording, and we don't know so much of technology, and we will get caught in such instances.
Anyway, Charmila, we will go to the next. I will project the CV of the. Thank you, madam. We stay with us because more questions will come. So we are going to the next. I will share the CV of the next speaker.
It was very enjoyable, Dr. Sarita ma'am.
Oh, thank you so much.
Learned a lot, actually.
Thank you.
It's my pleasure to introduce it's my pleasure to introduce a friend now, Dr. Radhika. She's going to talk on how to prepare and present papers and posters. Radhika, there are already so many questions in the chat box on that. I think you will do justice, we know that. She is a recipient of the ICOG Visiting Professor Award in 2019 and the recipient of the Foxy Korean Award 2019, and the Foxy Best Paper third prize in 2016. She's a national coordinator of the Foxy Clinical Research Committee, and she was a coordinator when I was a chairperson also, and she's done such good work for the committee at that point of time also. And I know she's doing a great job with Meena also now. And it's a great honor to have you with us in our committee always, Radhika. And she's a chairperson of the Multidisciplinary Committee of AOGD in 2018 to 20, chairperson of the Skills Workshop AOGD 2017 to 18, editor of the newsletter of NARCHI Delhi, member of the Cochrane Collaboration, member of the Campbell Collaboration. She's an expert reviewer of the Cochrane Group in Gynec Oncology and in the Wounds Group. She's a member of the South Asian Cochrane Network, member of the Guidelines International Network, expert reviewer of JOGI, IJMR, JSA, FOG, and she's got several publications in international and national journals, and she's edited 2 books, and her special interest and expertise is in evidence-based healthcare and guideline development. Over to you, Radhika.
Thank you so much, Charmila, for the kind words. And I think it's a wonderful initiative led by Dr. Alpesh and the entire team. Many congratulations and my appreciations to you, Charmila, Ashwath, Shashwath, Niharika, Rohan, the entire young team that is there involved in this. I am very glad to be here and thank you for inviting me. So, paper and poster, believe me, a lot of changes have happened in the past few years. And during the course of my preparation, I myself have learnt a lot. So,
okay, we are seeing you.
Yeah, that's great. So today's focus is on basically the paper presentation, so the oral, poster, and the e-poster. Whatever be the type of presentation that you do, the basic principles in all the 3 types remain the same, and that is the first principle, meaning have a logical flow, have one idea per slide, It should be relatable to the audience. Keep it simple and keep the transitions between the slides also simple. Don't make them, let's not have distractions between the slides. And the best part of a scientific presentation is that it provides an opportunity to summarize your research work and public speaking. And it also helps to understand the various aspects of the study better. And that helps you to bring out a research manuscript for publication, which is already peer reviewed, free of cost. And you also get recognized as a worker and a budding expert in the chosen field. And it is, of course, an opportunity to interact as well as have collaborations with other people in the same area. And certainly it improves the CV. So it is always a good idea to present the paper. Always remember, initially the attention, the curiosity is high. And then there is a fall. And then when you start concluding, people wake up. So this is to say that your opening sentences have to be smart and try to, bring out some important salient part of your study in the initial few slides. And then, of course, you discuss on. So it is also important to remember that the presenter is a part of the visual experience of the presentation. So dress well, look well-groomed, look confident. You need to look happy and rehearse your slides well, know the subject details well, organize all the data and presentation, and most importantly, time it. Time it to less than 10 minutes. Majority of the talks are anything between 10 or 12 minutes. Rest of the time, about 3 minutes are left for discussion. So it is very important. What you have done over the past 2 years, you have to bring it into 10 minutes. It's like you have done all that cooking, you have to present it well on the table to be eaten. It's a delicious food. It has to look good and it has to be assimilated well for people to appreciate you. So the tips of presentation: speak slowly and clearly. There is no hurry. You need to time yourself well. It is a good idea to start, practicing the opening sentence. What happens is once you get onto the podium, it's a new experience and you see such a lot of faces. Now today I'm sitting at home. I can't see any face at all. I'm just seeing my slides. Whereas when it is live, the feeling is completely different. The energy flows. So when you see so many eyes looking at you, you start fumbling. So it is a good idea to memorize the initial sentence. Very good morning to all. Very good morning to the chairpersons, my respected chairpersons, teachers, friends, and people in the audience. Anything that you wish to greet with, memorize that so that rest of the thoughts flow. Once the beginning is good, the flow of the language, everything becomes much easier. Highlight the importance of the study. Usually the title slides get projected, the slide gets projected when you get onto the stage. Don't spend time paraphrasing and repeating the title. Just start with the highlight and the importance of the study. Like I said, within the first few slides, what you speak is what is assimilated well. And don't be in a hurry to go on changing the slides. Give the audience some time to look at the slide. It is very important to spell check and correct the grammatical errors. Extremely irritating to see grammatical errors and improper spellings on the slides. Now, what happens is when you are preparing the poster or the slide, you've spent so much time trying to do that. Slowly and slowly, the eyes they miss the mistakes. So what people say is you read it in the reverse order. So if this line were to be read in the reverse order, many of the spelling mistakes get picked up by the eyes. And this is what I learned now. And when I practiced that, when I tried doing that, it really happened. So I think that's a great idea. Do reverse checking. Be visually consistent. Have the same set of design and color scheme as far as possible for most of the slides, especially with concern to the graphs and the visuals. Now, people might feel it becomes monotonous, but then the graphs are there. There are other kinds of distractors or probably some sort of soothing for the eyes, which we will just understand in the next few slides. So visual consistency helps the audience to understand the scheme better, absorb the information better. That is what is the basic aim. Synchronize between what you speak and what is getting projected. Don't talk about the previous slide or the oncoming slide at the time when something else is getting projected. That is extremely distracting. Speak to the audience, look into the eyes of the people who are sitting maybe in the last row, front row. It is important for you to look at the audience. Don't there is nothing to feel hesitant about it. Don't go on looking at your laptop or the projector screen. Eye contact helps to maintain interest amongst the audience. And in case there, today most of the talk gets recorded. Like today, Dr. Alpesh said, these programs, our sessions are going to be now put up on the website. So you have to be smart. In between, look directly at the recording camera. So this gives the audience an idea that you are looking at the people who are sitting at home or wherever they are. And it again gives a personal touch to your presentation. It is also a good idea to come prepared with some questions. Prepare a few slides as a response to those questions. And in case you get asked if those questions get asked from you, just project those slides, and it is very easy. Finish within the time allocated. So generally allocate 1 minute per slide. So if it is 12 minutes allocated to you, then use 12 slides. So there is one introductory slide, like you have your name and all that. Last is a thank you slide. So probably you could remove that. In total, you could have about 14 slides. See, as a young person, probably you may not get asked these nasty questions. There are people who have a habit of speaking in a irritated tone, or there could be people who are just trying to, spoil the game for whatever reason. That with experience, you learn to tackle that. It is important to be able to tackle that. Don't lose your patience. Come back to the point where both of you agreed at the initial point, and then start from there again. Turn around, ask what is the problem that the person is differing with, what is exactly the point of difference, try to sort it out. In case it doesn't get sorted out, you can always say we can discuss over a cup of coffee or lunch or whatever. So don't feel scared. The idea is don't feel scared. Always smile. Both enthusiasm and boredom are contagious. So you look confident, you smile, and you say we will have this discussion over a cup of coffee. Nobody can touch you after that. So the suggested sequence for the research paper presentation, there is a title slide, competing interest or declaration, introduction, objectives, then methods, results, discussion and conclusion, and finally the acknowledgement. There is also the space for reference. So title will also have the names of the author and the affiliations, and then competing interest in case there has been any financial. Basically, the conflict of interest is financial, which is very, very important to be disclosed, because the entire research work today depends a lot of it on money. Funders are not easy to come by. People take the lean on the various kinds of financial institutions, especially the pharma. So there is a dilution of the effect of results when you have any kind of financial conflict of interest. But it is important to say so. There could be reasons why one had to undertake that, but one has to be clear. Introduction gives the reason, the justification as to why you decided to undertake the study. You give a basic brief background of the information that is already available, and then the gaps in research and why you decided to do that. Do the research, and then state the research hypothesis and also the PICO question. Followed by the primary and the secondary objectives, and then the methods. When I speak about the methods, what we find is majority of the time, people go into too many details about the methods. It is really not required. Give an overall gist. There is a time limit in your presentation, whatever be it, oral, or you have the poster or whatever it is. So maintain a brief flow chart sort of a thing, especially in both the oral as well as in the poster presentation. It is a great idea to have a flow chart, but it is important to mention the study design, the place of study, the duration of the study, and the statistical plan. Complex methodologies may require 2 slides. Results provide the numerical data, and use tables and graphs where relevant. Where to use tables and where to use the graphs, I'm just going to address that in the next few slides. Now, when it comes to the discussion, describe what new evidence has been provided. It is very, very important to critique your own work. Talk about the limitation and strength of your study, the overall evidence of result, and also whether it has helped you to change your practice. Does it affect the policies or the change in the thinking process of the professional in your area of work. What are the directions for future research, and is there a take-home message? Very important to acknowledge the help and assistance of the funding agencies, individuals who help to provide intellectual inputs and other support. It is, whenever forming a research hypothesis is not easy. Identifying your research topic is just not easy. So there would be so many people who would have helped you on the way. Remember, gratitude is the best attitude. Now, let's come to the slide formatting. It is very important, like I said, presenting the food on the table is what ultimately matters. So orientation of the slide is usually landscape. Now, two things which are very important for the slide, other than formatting the slide, is the color and the font. Today, people talk a lot about the visibility and the assimilation of information based on the color and the font. So let us, spend a few minutes trying to understand the basics of the color. So the background color provides a high contrast with the text color. The background could be white or it could be black or blue. So when you use a white background, it is better to use a contrasting color like black as the font color. When you use the black color as the background, use yellow, or you could use white or orange as the text color. And now, if you were to see here, the background here is green and the color of the text is red, doesn't show up well. Same is the case here, same is the case here. So these are not good ideas, whereas these are good ideas. You have a low colored background with the text which is standing out. At the same time, it is important to avoid a loud garish color, the bright fluorescent green with red. Same is the case with the blue and yellow. And mind you, there could be people who are colorblind, who are not able to read or not able to see what you have written on the screen. And avoid red or green, as they do not project well. As it is, even on a white screen, if you were to use red or green fonts, they don't project well. Do not use too many words in a line. In a line, not more than 5 to 6 words, and in a slide, not more than 6 lines. So 6 by 6 rule is a good idea to follow. Always leave a margin of about 1 centimeter between the lettering and outer margin of the slide, and make duplicate slides if you need to refer to a slide more than once. Don't go on going up and down, and it is extremely distracting and troubles the eyes. So you can make the slide twice. Keep the text to the minimum. Select good quality, good and easily readable fonts. Usually, by and large, in the slide presentation, it is a good idea to keep the title at 36 to 40 fonts and the body at 24 to 28 fonts. Basically, because when people are sitting at the back of the room, they should be able to read the slide that is getting projected. And for emphasis, increase the letter size or make it bold. It is not a good idea to underline the letters. Use italics sparingly, use underlining sparingly, and avoid acronyms and jargons unless they are standard. For instance, WHO, everybody will know, World Health Organization. Whereas if I say GTB, that's the name of my hospital, Guru Tegh Bahadur Hospital, not many people will know. So it's not a good idea to use those kind of acronyms and jargons, or wherever you use, provide an expansion at least in the first slide. It is important to remember, never use all caps. Not a good idea at all. I will just show you why. Space letters for legibility. Lines are required to be distributed evenly and uniformly. All of us understand this. It's a very simple concept. Use multiple simple slides to explain a concept. Avoid using flowers, sunsets, fancy clip arts, and those kind of distractors in a professional slide. So now we come to the fonts. Now, there are basically two types of fonts. One is we start with the serif font, okay? There is a sans serif font, and there is a serif font, and there is script. Script is like handwriting. As you can see here, it is like the handwriting. It is very rarely, almost never used in the slides. Nor are these used in the posters. So the basic principles of posters and the slides remain the same. Now, serif fonts are the ones which do not have these kind of tails. Now, the serif fonts have these tails, at the end of each letter, it gets pulled. There is a tail or there is a wing. And this is there, like, for example, we are very used to reading text in Times New Roman. Our eyes have an ability to take in the flow of the serif fonts, and these are generally used for the text, the body or the text. And majority of the times, and what is recommended is to use the sans serif. When you say sans, it doesn't have the tails. It is sans the serif. So sans serif font is used for the title. So today people have come out with good combinations. What are the titles with which you can use the body text? For instance, you can use Arial, which is sans serif with Georgia in the body text. Times New Roman with Helvetica. So these are combinations which are standard, well tried. People have appreciated these combinations, and these are good idea to use on your slide as well as on the poster. Now, by and large, if you ask me, I am a very conservative person. I like to use only one type of font in the slides that I use for projection. Of course, posters I have a different choice, but the PowerPoint provides us with good number of choices for our projection. So I generally prefer to use Calibri and Calibri Light and Calibri for my projections, and that is the one that I'm using for the current presentation too. So Calibri Light is used for the title and Calibri is used for the body text. Then the ones which have been asterisked are the ones which are popular. So it could be Century Gothic, Century School Book. Then Comic Sans, few people use basically to highlight certain matters. So these are the ones that are there, and these could be used for the projections. Now, what about webinars? Is it any different for the webinars? Today, the accepted point is, because we are again projecting the same slides and people are also sitting in their homes and using the same slides. It is these combinations are well accepted. The size is a little smaller because people are sitting closer to the screens. So the title could be around 32 or 34, and the body text could be 22, 24, or 28. So that gives a pleasing look to the slide and is easily assimilated. Avoid sound effects, not good at all, because not only it distracts, it also it decreases the rate of transition and of the slides, and also the borders. These kind of borders are not very popular, and they are generally discouraged. So you see, again, these kind of distractors, these are not a good idea to use, because I don't think even in the present slide it had great value. The idea was to show that it's not a good thing to use. Now, how to display the data? Now, we have the figures, the graphs, and also the flowcharts. Use the visual sparingly but effectively. So, generally when you have the slide or the poster, now, like for instance, when you see my slide, it has barely, how many lines? 1, 2, 3, 4, 5. There are 5 lines. So it is not very busy, and it helps you to read each line nicely and focus on what I'm saying. These are only cues. These are not going to give me the entire sentences and the paragraphs for me to read out. I am speaking to you and using these as cues to be able to get across the message to you clearly. So the figures, drawings, and graphs should be bold, simple, and contain only the essential details. And it is important not to use the grid lines. I hope you know what are the grid lines. So when you make a graph, for instance, when you use the Excel sheet, you have the grid lines which come on. Even without the Excel sheet, when you use the charts and the graphs, when you put them on the PowerPoint slide, there are the grid lines that come, and then you start making the graph. So once you have done that, you remove these grid lines. There is a choice in the PowerPoint to remove the grid lines. Then it gives a very pleasing look to the graph. It helps the observer to focus on the information that has been placed on the graph, identify the x-axis, the y-axis and the x-axis clearly, and then how to label them also, we are just going to understand. Ensure that similar graphs have the same scales. So where to put the graph and where to put the table? Graphs have they are better appreciated in presentations. So for instance, in the oral presentation, in the posters, graphs are better, and tables are better appreciated in publications. Graphs only show summary, and these can show almost the entire data. Graph has only few variables. This can include multiple variables. It shows a better trend. The trend is better illustrated with the graph, whereas the trend is very poorly illustrated by the table. Now, when you have, these kind of tables, now you have so many variables. These are the various kinds of drugs, detection period for drugs. Now, if I were to make a graph of this, then it becomes extremely busy, very difficult to understand. So in this case, table is the preferred one. So the table, however, should not be too big, and highlight the important numbers with bold, type, or different color that require to be discussed. And then you can discuss. Today I have the advantage of having the pen in my hand. I can just underline or pick these out and be able to, focus on those. Now, look at this. Now here, what is happening is there is the urinary excretion of prostaglandin metabolite with indomethacin administration. Now, there is something that is happening between day 2, 3, 4. And, when I look at this, I'm not interested in going through this and trying to understand the figure. Now, if you look at this graph, very clear, it shows the change in the trend. There is initially so much, and then it falls, and then it rises again. So the trends are better illustrated by the graph. So that is the take-home message. So how should the graphical data be presented? It can be in any format. In any format, the data presented should include a clear title, labeling, legend, and correct units, or usually the metric is used. Now, it is important to remember, don't use 2-dimensional and 3-dimensional graph because they are difficult to read, difficult to understand. Preference is unidimensional graph, and then label the axis well, and preferably, now in this case, it is labeled vertically. As far as possible, use the horizontal system of labeling for easy readability. And then there are various types of graphs. There could be bar, pie, scatter, line, there could be stem. Sorry for this. It is stem and leaf. So like I said, these kind of errors in spelling can be distractors. So then there can be whisker plot. There could be a radar plot. So now, for instance, this is a bar graph. So so which to use where? That's important to know. So bar charts are basically for categorical. There are various kinds of data. So today we are talking of basically the quantitative kind of studies. So the data could be there could be the continuous form, the numericals, or the categoric forms. So when you have the categoric forms, the bar chart and the pie chart could be preferred. Then this is the segmented column chart. It gives the frequency, for instance here, frequency of bleeding gums of women in different types of bleeding disorders. So once a week, less than once a week, or it is never. So there are various types of women, hemophilia A, B, then there is von Willebrand, and then factor IX deficiency. So how do I project this? So here I use the segmented column chart. Histogram, the dot plot and the scatter plot are very good for frequency. And then the dot plot helps you to also show the median age, the median figures in the continuous variables, that is the numericals. So which chart to use where is also very important to know. And there are suggestions even on the PowerPoint slide. When you use a chart, it gives you a quick idea as to which chart is best applicable for your data. One point I wish to say is never misrepresent your data. Now, here I have taken something completely non-medical. This is the approving ratings of the presidential candidates. Now, this looks as if Joe has got, it looks abysmally low. This person seems most unpopular. Now, see here, the approval ratings, they have started with 20, 25, 30, 35, 40, 45, and so on. Now, the same thing I see when I change the data set here, Joe is not so bad. See, people have got till about 50, and he has got till about 20, 23, 25. Not so bad. So when you change the y-axis and the data set, the intervals, it can completely reflect differently the information. So this is very important, especially in a poster. But if somebody were to sit and stand and read your poster, this information, the misinformation can be very easily picked up. Whereas when you present the slide, oral slide, it may not be picked up so fast, but then there are people who are sharp at, observing this. Now, look at the result that has been presented. It is a huge paragraph, randomized placebo-controlled trial having 303 subjects, 2 and 3 so blah, blah, blah. So then finally the placebo, I don't know what happened to the results. Whereas if I were to present it like this, it becomes so clear. So you started with 303, and then there were so many withdrawals. Here only 2 withdrew, and then finally you can have the footnote, which finally gives the summary of the results. So it is very useful to use the graph and the flow charts, effectively. Then you come to the figures. Pictorial representation of the data finding or the process, may not be available on the internet or anywhere. Sometimes you need to make your own. You hand draw it, use the services of an artist and get it made. Number 2, if you were to use a photograph, the preferable resolution is about 300 dpi. So because when you enlarge this, when I enlarge this, as you can find here, there is pixelation. This doesn't look good. So a high resolution figure photograph is better used in whatever be the kind of presentation that you wish. Now, flow charts are a very good idea to present your methodology. So now this is the Equator network, where you get various kinds of reporting guidelines. Now, for randomized control trials, you have the CONSORT, then you have the STROBE, PRISMA, and all of these also have the flow diagram which is available. For instance, I have taken the CONSORT flow chart, which just needs to be filled in. Now, this is so standard that if you've conducted a randomized control trial, and if somebody were to have a look at this, they will immediately know that you have worked as per the guidelines. And then it also gives information in a very concise way in one place. So flow charts, where applicable, are a great idea to use. Finally, the discussion. It is important to present how your study was different or unique from the others which are already in the market. Very, very important to clearly link the objective and the title to the discussion and the conclusion. Majority of the times, that is what happens. You start your protocol with a certain thing 2 years back, and down the line, something happens. You're going on working so hard, and when you finally write your project or your thesis, sometimes you miss the point and you end up stating something else. You think that is very important. Most important, you missed it at the time when you wrote the protocol. That should not be the case. You could, mention that during the course of discussion, but in the conclusion as well as in the final paragraph of the discussion, it is important to link the title, the objective, with the final outcome of your study. Keep it concise, support your conclusions with whatever data you had already enumerated. You have to highlight the lessons that you learned through the study, and you can use subheadings for your main message. Critique the paper, like I said right at the outset. The strength and the weaknesses have to be highlighted. And what are the broader implications of your study for teaching, practice, further research, whatever it be. So this makes the discussion extremely interesting, and people would certainly appreciate this kind of a presentation. So what are the basic don'ts? Don't unnecessarily walk the platform. Don't go up and down, it distracts. Don't hold the mic too close to your mouth. Don't stand in the stream of the projection. You are so involved and caught up with your talk that you've forgotten that you are in the way. Nobody can see your slides. Don't use the pointer. You would see people using the pointer going round and round, or, just putting it somewhere on the wall or the slide, keeping it there. Not a good idea. Okay, don't go on using your pen and the pointer, going on clicking the pen, making it, making a sound there. Flipping the slides back and forth, not a good idea. Too much activity on the slide, transition, animation, colors and fonts, and then going on saying ahem, and those kind of when you want to think, keep quiet. You just take a minute, collect your thoughts and speak. Because when you go on getting these bridges, then again, after some time, it becomes repetitive. Same is the case with using these terms like actual, basically, generally speaking. I think so. In my experience, not a good idea at all. People are, in your research, of course, you experience that. But whether that is finally the take-home message, it's not very clear. That may not be the best way to bring it out. Don't drop your voice towards the end of the sentence. Maintain the same level of volume throughout the sentence. Those, like I projected on the initial slide, use the IMRAD kind of projection. Introduction, method, result, and discussion. Short phrases are better. Bulleted format is always better. Complex patient flow can be depicted using a figure, graph for displaying the data. Adopt a minimalistic approach, avoid clutter. Summarize complex data for easy understanding. And use of words has to be minimized. Always keep a copy in the cloud, pen drive, as well as in the email. At the last moment, there could be things that could go awry, there could be things that go wrong. So you start panicking. So it's always good to have a backup. Print handouts, especially if you have that kind of money and funding, it's a good idea to keep that in the preview slide, in the preview room, or also in the presentation room. Give it to the delegates where possible so that they're able to read it. Always carry with you an HDMI and the VGA cable or converter. At the last time, for instance, I have an iPad. Many of the places don't have converter, and because of that, there have been huge problems. So always anticipate trouble. So despite doing the best of your effort, the Murphy's law always works, So you planned it this way. You thought you will start from here, everything will go smoothly, and you will hear the claps here with great appreciation. That may not be the case. There could be so many things that can happen. There could be the previous speaker who became late, technical difficulty in starting the slides. Then you forget to introduce yourself. Then you spend way too much time in the initial slides. Then you get motivated. You start speaking loudly and fast. And suddenly there is an annoying disturbance. There is something, the light goes off, whatever happens. So there is finally at the end of this thing, you have lost the plot. You are talking about this and that without remembering to speak the final conclusion. And the last few seconds is awkward conclusion, awkward silence. So in the question and answer session, you are fumbling. So be prepared. The initial few presentations are very exciting. I still remember in my initial days, it is very, very important, to practice. Stand in front of the mirror, use the voice recorder. We didn't have those kind of facilities many, many years back. But today you have those, and I encourage you to practice your slides in the initial few times. So quickly going on to the posters. Again, everything, the basic information remains the same. Basic advice remains the same. But a few things for a good poster. See, the point is that you are standing in the middle of such a huge crowd. And today, there are most of the conferences, the organizers want large attendance. So why should anybody stand and look at your poster or, the electronic poster? Why should it interest anybody? It will only interest when they know that the work that you have done is something that they are interested in. So your poster should catch attention from a distance from at least about 10 feet. Okay? So how do you do that? You need to present it well. You need to project your poster well so that it catches attention. So the display remains the same. Short title, name, affiliation. Use a word count of about 300 to 800, not more than 45 to 55 characters wide. So if you use the column for your column type of format for your poster that we would be talking about the next slide, don't use more than 45 to 55 characters. I will be talking about this again. Text should be clear and to the point. There is something called information hierarchy and visual grammar. I will be just explaining this. It's extremely important to understand this basic fundamental in projecting your good poster, because this is how you catch attention of the people who are there in the hall. Use bullets, numbering, and headlines to make it easy to read. Effective use of graphics, consistent and clean layout, include acknowledgements and references. This point is extremely important. 40% of your poster area should be empty. Okay? So in rest of the 60% of the area, 60% should be graph and only 40% should be text. So in other words, most of the explanation is given by the pictorials, very less by the text, and a certain amount of area of the poster is empty to give the eyes some rest and to maintain and keep the interest on. Limit use of boxes and lines. Again, not a good idea to use the outlines. So what is visual grammar? Visual grammar is the graphic hierarchy. So you start with the bigger letter, go to the lesser one and the small one. If you want to use the small one to catch attention, you can make it bold. And you could use various kinds of fonts. So it could be the size or the various kinds of fonts. And this helps the readers in identifying the most important part of the poster. And this results in the reader gravity. So when you have a poster, you start from the left, then it goes to the middle, and then it goes to the right. It goes like this. So this is called as the reader gravity, which pulls the eye from the top to the bottom, from the left to the right. Column format makes the poster easier to be read, and use of organizational clues, numbers, letters, arrows helps to guide the. So here you have various sizes. There could be various position of the text. There could be color. There could be texture, shape, orientation, which help to grab the attention of the reader. So this is the poster layout with the visual grammar. So you have the column style. You know, this has been formatted in the column style of presentation, which is largely accepted worldwide. And here you have the title at the top. Then you use the big words for the heading. Then you use the medium for the subheading, and then the text. And this goes on and so forth. So there is introduction, method, results here, result flows on here, conclusion and reference. So it is important that you have a certain kind of flow so that the reader is able to follow the path. It has to be logical. This is not a good idea. So here the flow is very good. So it is, easily readable. So this is the template that is usually provided by most of the organizers to organize your poster. So what should be the font? The title and the subheadings, the largest should be the title. Here I have written as 36. People have used up to 40 or even up to 50 to use on the title and the subheading. Text should be readable from a distance of 4 feet. The smallest letter should be legible from a distance of about 3 feet. So 24 for the text, about 14 to 18 for the smallest one. Use sans serif for the title, serif for the text, and don't use more than 3 types of fonts. So one is the sans serif, second is a serif, and third could be bold or something like that. Don't use too many types of fonts, because again it becomes difficult for the person to catch, to understand. And then like I said, it has to be 10 by 10 rules. Your poster should be, the major part of the information should be readable from a distance of 10 feet in 10 seconds. And that should draw the audience to you. So 10 by 10 rule is very important to be followed. Now, what about designing? Never use capital letters. See, if you look here, this all forms a rectangle. Our eyes are not used to seeing these kind of same sized letters. It is important to use these kind of letters, Now the downward strokes or the upward strokes, like in B or D, or the G, the downward stroke that you have in G or P, etc., are very distinctive. And this we have been reading from childbirth, this from the time we were born. So it is very easily readable. And this is what is usually preferred for any kind of writing on the poster. It is not a good idea to use all caps. Number 2, black or dark background when you fill it with the thin lines or the serif fonts, then they don't show up well because it fills up these fonts. So it is better to use the sans serif, especially in the title. This is the color plate which has been, or the color wheel which has been, which is standard used by majority of the people. These are the various kinds of combinations that one can use, yellow green with yellow orange, these are the pleasing look. You can spend some time, because there is a time constraint here. I can't be explaining everything, but this information is very freely available in the internet. I encourage everybody to have a look at this. Then there are various programs for designing the poster. So there could be the most popular one, and I personally use this is Microsoft PowerPoint. Then the ones who don't have access to the Microsoft Office, there is Open Office where you have Impress, which can be used for building these posters. Then, of course, you have the Adobe Photoshop and the Delta Graph, etc. So dress professionally, stand by the poster. It is expected by the coordinators that you meet them, they meet the judges. Be prepared to answer questions, but don't hurry. You wait for them to complete the question before you jump at the answer. You wait for the readers to finish. Put down any drink or food that you are having. Have eye-to-eye contact. Look confident. Straighten your shoulder. Look smilingly. Relax. Know the flow of your poster well and refer to it. So let me go on to the e-poster. Today, e-poster is dynamic. See, what is happening, I think in our country, it is still in the nascent stage, especially in gynecology. What people do is they use the same poster, the static poster, to the same format as the e-poster. Now, that is not the case anymore today. E-poster gives you a large variety of activities that can be undertaken, and it can be made extremely attractive, informative, because of the dynamic nature of changes that can be inserted or embedded in the e-poster. So the other standard poster ideas apply. But an e-poster is, like I said, it's not merely a poster which is printed on a paper. One should fully utilize the power of electronic medium. One has the choice and today the facility to use multiple audio, video, enlarged graphics, and hyperlinks that may be used to the e-poster. Now, it is a good idea for everyone to have a look at the e-poster site and the American Heart Association, where there are a lot of templates and examples of the e-posters which are available, and one could have some ideas from there. Now, when I say hyperlink, I just wish to focus a little on this. See, for instance, if it is a surgical presentation, see, when do we prefer a poster? When do we want an oral presentation? Generally, an oral presentation is preferred because, the organizers as well as the presenters, they feel oral presentation is the elite form of presentation, whereas the poster presentation is a step down. Whereas I feel that is not the case. Each has its own place. If your study is complex, which is difficult to explain, poster is a choice. You have the ability, you have the facility and the choice of putting out the figures in the diagrams, stand there and explain. It is a two-way process. It's not a monologue. Today, I'm just speaking to you. You would be posting your questions in question and answer, and we will answer. Whereas in the presentations, only 2 minutes are given for discussion, and it becomes difficult to answer all the queries. So in simple sort of presentations, yes, the visuals are the better ones. But when it comes to surgical presentations, certainly probably oral is the better one to project because it gives you the option of running your video. But today in an e-poster, you have that too. But you may not be able to have the entire surgical video presented on your e-poster. So in that case, you can use these hyperlinks. So you put your hyperlink there, and when the audience clicks or you click on that, it goes to your YouTube upload, and you can very nicely show your presentation, your video, whatever is the upload there. Same could be done with your references. In case of open access journals or cross references, these can very easily be accessed. There could be somebody who had published a paper, you have cross referenced that person, you have given a reference to that person, and you wish to have a look at that reference. You feel both of you would be so excited to have a look at that publication. So that kind of a two-way interaction happens with a poster, which may not be possible in an oral presentation. Number two, the poster is permanent. It's that kind of the presentation remains. Whereas in the memory of people, the oral presentation today, we have these projections which are available in the websites, but that may not be the case. Majority of the organizers may not be putting the free papers on the websites. So the posters have got a greater span of remaining. However, the cost is more. Carrying the poster is difficult. You only have to have a pen drive or a projection on the cloud to have your oral presentation. So those kind of basic differences exist. So one has to be clever. One should know where to use what kind of diagram, what kind of graph. And then finally, the e-poster. Today, it opens an entirely new arena of innovation and use of medium to project your work. So there are various softwares available again. So it's a good idea if you could visit this website. And also ePost is a software that is available to develop your ePoster. So like I said, you could embed your slideshow, your video, the front page, link your references, YouTube videos, everything is possible today through the dynamic poster. So a word of caution, what should you be using when you use these on your ePoster? Preferably use videos in the MPEG-4 or MP4 AVI format. Audio, I would suggest don't use audios because they have been notoriously known to malfunction. But if you were to use that, use the WAV or the MP3. Still graphics, like I had focused initially, better use higher resolution. BMP or TIFF are good ideas to use, though they make the file heavy. Others could be JPEG, GIF, PNG. I'm sure most of you are aware of these. And then, where you have the touchscreen sort of a thing, always include the hyperlink at each page so that you have the ability to go back to the home page, because during the course of discussion, one may get lost in the entire maze of hyperlinks. Always have the home page hyperlink in each page. You could have detailed access to the graphs as well as to the raw data. So that is how the e-poster is different from the page, the printed one. High contrast, again, the same rules of projections apply here. High contrast is important. Dark lines on a light background. So the background and the foreground, we have already focused on all this. And colors that look good on your computer monitors may not be necessarily projecting well. So you can just go through the various, there are various college sites, the educational sites, especially the Western colleges, which give you some kind of basic advice on how to project your data. So it is always, updated with every passing day, because new software comes, new ideas come. It's a good idea to just have an overview, look at those sites. Now, finally, after having done all that, you still need to see from the judge's eye. So how do the judges, how do they give marks to your presentation? They need to understand whether it was a significant subject, whether it increases the understanding of the disease, improves the diagnosis or the treatment, whether the presentation was logical, interesting, clearly written, free of grammatical errors, whether the visual impact was good, effective, whether the figures and the graphs were used nicely, appropriately, and whether you were knowledgeable and conversant about the subject and the very research that you had undertaken. So these are the nuances and the important facts of the presentation. These are examples of some bad slides. So very loud, hardly legible, hardly seen, font is too large, too colorful. This is, nobody can read this, obviously. These are examples of good slides. It just cools down your eyes, and you feel like looking at these slides. You can use graphics like this to be able to get all your message in one slide and make it more effectively understood. These are bad posters, dark background, there are too many graphics there. They are placed at various points. One doesn't understand what one is trying to convey. Too busy, not able to understand. Probably this may not be too bad, but when I had a closer look, the written matter wasn't very good. The results are placed here. The visual impact is not so bad. Whereas these are good ones, there is a logical flow to this. The reader's eye goes from here to here. There is a flow of thought as well as the presentation and pleasing to the eyes. So with that, I hope I have done justice to this huge topic and somewhat clear in what I've been trying to express. So thank you all for a patient listening.
Thank you, Radhika. It was so comprehensive. I will never use R anymore. I'm scared now. Totally scared now. And no more actually and gradually. I'm really scared of using some words now.
And believe me,
you made your point clear.
I was myself now feeling diffident, whether I will start using those words.
But you put your point across so clearly. It was so clear. There are 2-3 questions to you. There's one from Vandana from Patna, and she's asking, the slide should include new and relevant things or everything concised, including the basics.
No, which slide? So for instance,
get
if
the
it is a background or the introduction, it's always a good idea to flow
Yeah.
from what is already available in the literature and go on to what you're going to do, why you did that, why the thought came at all. So it's a good idea to provide a brief background. Don't spend too much time on that, and then come on to your research question and how the research point came to your mind. So that would mean the recent literature. So go from one to the other. So it will not be focusing only on one aspect.
Okay. There are 2-3 questions from a person called Faika and from Coimbatore. And I don't think it's much relevant to your topic, but I think you can take the question.
Right.
She's asking, like, if we submit an article to a journal, what is the ethical thing to do if you haven't received a response from the journal after 6 months, even after trying to contact them? Can I submit my article elsewhere?
No, you write to them. No, it would be a good idea to write to them and say that you've been waiting for some time. You have that kind of evidence to show that you have written to them again and again. And then if they still don't respond, then you finally inform them that you are now dropping and tell them that you are, retracting your paper from there, and then go on and submit to the other place.
Okay. So and the second question is, if I have presented a study as a poster, can I write an article on the same study for publication?
Yes,
or
of
does
course.
It involve some sort of copyright imprint?
Not at all. If it is your work, you have presented a poster, you can jolly well go and publish a paper. That is the way to do it, actually.
Okay. And there's one question that's like, are letters to the editors considered as articles?
It depends on the letters to editor in the Medline journals, the index journals, whatever be the indexing agency. So if it is acceptable to your employer, yes, of course, those are accepted.
And can it be added to the list of publications in your biodata?
Yes, it can be.
And some journals have a separate section for postgraduates. Do they have any value?
I'm not too sure about the postgraduate part, but if it is an index journal and it's letting you, for instance, one of those major journals, I forget the name, it has a section for the postgraduates, and these postgraduates are mentored by their supervisors, and they project themselves as for instance, IGMR. There is a special session at the end of the short-term studentship. They come out with a special section for their students only, the IGMR, and that is indexed. That is considered as a publication, and that can be added and mentioned in the CV.
And Madam Professor Dr. Chellama from Kozhikode, she's asking, what is iPoster? Is something called iPoster?
iPoster? I am not aware. I don't know.
Okay. You can answer privately to her later. I'll give you the number.
No, maybe anybody else. If somebody else knows, he can give an answer.
No, I'm not sure.
Okay.
Probably Madam meant as e-poster, right?
So the e-poster were last 4 slides of mine that was
there. That was explained well. Anyway, if the questions are over, we will go.
Some questions for Dr. Sarita Ashwath. Can we ask that or later?
No, she is there. Sarita Madam, you are there? Sarita Madam? I think she is not there. We will ask after the next talk.
Okay.
So now, next for moderating the next 2 sessions, we have Niharika Malhotra. She is the consultant in Rainbow IVF Agra, and she is a practicing obstetrician in Malhotra Nursing Home, and she is the director of Rainbow Wellness Clinic. More important is that she is currently the youngest chairperson of FOXI. She is the chairperson of Young Talent Promotion Committee and executive member of Society of Fetal Medicine. And she was served as the joint secretary in 2018 with her mother when she was the president. So she is like Rohan. She is also a daughter of both, where parents both are FOXI presidents, past FOXI presidents. Anyway, she has many awards to her credit, and she is now a part of our team of FOXI Forum, managing the FOXI PG Forum. So without any delay, now she will handing over the mic to Niharika to introduce the next 2 speakers as well as conduct the question answer session. Niharika, mic is yours.
Thank you, Dr. Ashwath, and really heartfelt thank you to Dr. Alpesh sir for organizing such a wonderful program. I was just imagining that when I would have been a PG and if we would have such lectures, I would have won a lot of poster and paper awards, because the amount of information which I got today was really wonderful. And I really congratulate Dr. Sarita and Dr. Radhika. And it was really too good. I think I hope all PGs were listening to all this. And without fail, we will now from the papers and posters to shift to how to write an article. It is such an important topic, and all of us, including me, are actually scared to write an article somehow. And I think Dr. Mohan sir is one of the best who will explain us on how to write an article. So welcome, Dr. Mohan. Dr. Mohan is a professor of reproductive medicine in CMC Vellore, and he is also the editorial board member of Cochrane Fertility and Gynecology. He has been the associate editor of Cochrane Clinical Answers, and he has a lot of degrees to his, as you can see on the slide, he is the faculty for postdoctoral FNB fellowship courses and for reproductive medicine surgery courses. He's also had a huge ResearchGate score of almost 33.09 and almost more than 70 publications under him. Welcome, sir, and we've all from our PGs welcome you today.
Thanks, Niharika. Am I audible? I'm okay?
Yes, very well,
thanks.
very well.
So I'd like to thank again Dr. Alpesh sir, Dr. Archana madam, the Foxy, Ashwath, all colleagues. It's a great idea. I'm on here for the second day. So I'll just move on to the topic because it is important topic that all of us know. It's about writing a paper and finally getting it published. So till now, I think most of our talks have been all about planning research and presenting. Of course, Dr. Radhika madam's talk also was focusing on showing off our project, our research project. So this is one step further. That is now you don't have the live peer review going on. You will have somebody sitting there and reviewing your work. So it's not going to be easy. So it's important that all of us understand how to write a paper. So, I'm going to introduce the topic. It's not very long presentation. Probably I'm timing it around 30 minutes so that I can take a lot of questions. So I would encourage all the postgraduates to come out of their shell and start asking questions, because that's the best thing. We all get encouraged if you ask a lot of questions, and I'm keeping it short so that you have your chances to ask questions. Yeah. So I'll be talking on few things broadly about how to write a paper. And also where to publish. Priya has covered this yesterday, so I'm not going to dwell in detail. Couple of things about how to handle rejections, because we all will go through rejections all the time. So it is something that first we need to understand, why do you need to write a paper? So yesterday I was talking about why do you need to do a clinical research. Today I'll be asking you all to look at why do you want to actually write a paper. Okay, so the foremost reason is, of course, you realize that you have a very tough research project going on and you've completed with so much of hard work. It can be your thesis or any other project. So it's obvious that somebody has to sit down and write it and publish it. That's the logical conclusion. Looking at the broader picture, it's about sharing the newer findings that your study has with the community. Community means your peer group or your patients, to the larger world. The whole world is your audience, and you need to share it, because we are out here to help people with whatever findings that we have found, so that their lives get better. So somebody might benefit from what your findings are, let's say across the continent. So that's all. It is the main reason why you should actually publish. As you publish more and more papers, especially on your original work, it is bound to have impact on your knowledge base, because when you write up a paper, when you do your research and write up a paper, you are going to do a lot of reading. Okay, so it goes with it. So the more the publication, in some ways, it directly correlates with the knowledge base. That is something that I really believe in, because every time I write a paper, I need to do a lot of background reading. Even before launching a study, you do that. When you write a paper, you again do the same. You kind of go one step further, because you have to start quoting studies, so you have to understand, paraphrase, so on and so forth. So more publication is essentially more knowledge in areas that you publish. your CV definitely looks much stronger because all of us have enough clinical experience. In India, there's no dearth of clinical work. All of us are good, expert in so many, procedures and so on. But this will give you the cutting edge, I can tell you that, okay? Now, I have found even, the CVs of big researchers carry their RG score, their H index. RG score is all about your research output, your followers, how many recommendations, and so on. H index is something that is to look forward to. It's about number of citation your paper has received on an average. So if you have a citation of, let's say, 15, means that 15, on an average, your paper is getting cited 15 times. If you have 10 papers, that's the way it is counted. In fact, if there are now people who suggest that if you want to become a prof in a medical college, your H index should have reached beyond 15. So it should be between 15 to 20 and so on. The top scientists and all, actually, their work, their H index goes up to 70, 80 and so on. That means on an average, their paper is cited 70 to 80 times. So that's the new world. So all of you should be aware and start looking at boosting up your RG score and H index. Coming to the actual study, what I want to stress again is, yesterday there were a lot of questions on whether we should go to ethics committee, review board, and so on and so forth. I believe truly that all the research projects should have a proposal and a protocol in place, and it's a good exercise to go for a research board, okay? That is where you will write your plan, discuss it with your peer group, and let a third party look at your studies, okay? Because their inputs could be very valuable, because once you launch a study, you find that results are not good or it's not done properly, then there's no looking back. You're done with it. So a protocol or a research project application to the ethics committee, the proposal is very important. I would strongly suggest that the introduction written there is partly the introduction of your paper. Okay, the paperwork starts right from there. Your project, the introduction that you have written for your protocol, that is the ethics committee protocol, the proposal, whatever you call it, the introduction is almost the same as what you're going to write for your paper. During, also in the protocol, you will mention how you're going to carry out the study. So the materials method part is also to an extent written during your proposal itself. All you do is during your study, capture all the results, the data and the results, compile the results doing the statistical tools that you have planned for, and there finishes the results. So by the time your study is actually done, that is, you have finished your project, you're already done with most of the 3/4 of the work. That's just the discussion that remains. So in my mind, the bottom line here is writing a proposal for review board is important because it kind of finishes at least the introduction and materials and method section. Now coming to the paper, this is hard work, okay? And in India, it is double, it's a lot more of that, because you have to find dedicated time between your postings, your labor room, and then your family, and all the things that go on. In that, to squeeze in the research time is going to be a challenge. It will mean some lost weekends, lost movie time, or a lot of family time, and so on. So that is something that we can't really crib about. We'll have to, if you have the passion, you need to look at that. You need to find ways to squeeze these things in, because research requires a lot of time. So writing paperwork requires free mind. You can't be disturbed every 10 minutes because it's not easy to get back to the flow. Okay, I prefer dedicated time for this. Plan in advance. Let's say you keep a weekend and you start. What I do is when I start a project, I make a folder on my desktop, and everything right from the protocol, proposal onwards, for everything that happens for the study, it keeps on getting collected in that folder on my desktop. And once the study is done, the results are generated. It's still on the desktop. Finally, when I write the paper, section by section, I keep on putting in that desktop till that folder moves out of my desktop and gets converted into a publication. I will not rest. That's the way I work, and I feel it's a good way. That is, you make a folder for a study, and all the relevant material of that study keeps on getting piled up in the folder. So that's something that is a startup tip. Now, writing a paper is about art of packaging a good research work. Okay, if you have a good research, that means that's a prerequisite. All this has been told to you in the last few talks is all about how to plan a good study. We hope that you conduct a good study, but finally, when the work is done, it still needs some work. That means that somebody has to sit down and write that and package it well. Then it will become a good paper. If you have done a good research work but written a shoddy paper, it's not going to make the cut because there are enough and more good work going on across the world. So remember that it's about art of packaging. So the first step is introduction. Now what happens is we have this bad habit of what is written in thesis. So we write very lengthy introductions, which is not exactly what is required during a manuscript writing. It's about some 4 or 5 paragraphs. The first paragraph is about describing the problem or the population you're targeting. So let's say if I'm from infertility and I want to talk about IVF, I'll talk about the infertility population. What's the burden of the problem and so on and so forth. Prevalence of infertility and so on and so forth. Then I will come to the intervention. What is my intervention I'm talking about? That means, let's say I'm talking about, freezing, freezing of embryos and all. So I'll talk describe the intervention. That's my second paragraph. The third paragraph is very important. That is where you'll put few studies with very few sentences for each study, saying broadly what those studies meant, what did they convey. Important is you will try to highlight conflicting nature of the findings of the previous studies. That means that I had asked this yesterday, you launch a study only when there is clinical equipoise. That means there is ambiguity. So when you write the introduction, you kind of convey the same. That means that you tell, okay, some studies favored the intervention and some studies did not favor the intervention. And we as a reader or a clinician, as a patient, we are confused. We believe that this drug works. So we want to clear the ambiguity, and that's why the study is being launched. This is all that is required for introduction. So introduction should ideally be between 800 to 1,000 words. Start writing lengthy introduction, you are going to put off the peer reviewer. Verb tense is present. Important is quoting landmark studies. Now, this is very important. I'll dwell again on this. Avoid lengthy introduction. I have something mentioned already. What not to do in introduction? Writing lengthy and vague introduction without focusing. You write everything under the sun about that topic, and then there's clearly it indicates to the reviewer that you are not really focused. You don't know what you really want to. The second thing that is very important in all aspects of research is not quoting landmark studies or the primary references or quoting out-of-date studies. It tells me as a reviewer that you have not really bothered to check what were the studies which kind of changed the intervention, what it was. There can be some very landmark trials for everything, like the term breech trial for the breech delivery. It was a landmark study in our times. Similarly, like for IVF, there is some like recurrent implantation failure or endometrial scratch, there is trophy trial. So I can name those trials for interventions. So those studies, if they are not quoted in your introduction, it tells me a lot about what, how much of work has been done by the primary author. And this is something that all of you need to focus on. And this will come how? It will come by literature search. You should have done this all before launching the study. Moving on to materials and methods. From the protocol, that is what I mentioned, the proposal you submit to the ethics committee, almost the same thing. So you make your proposal in a way, write it in a way that the same thing can be carried forward, at least most of it, for the article, that is the paper you're writing. Okay. Now describe the materials in sufficient detail. What I want to highlight here is the main idea of materials and methods is that tomorrow, if any other group, let's say sitting in Delhi or New York, wants to do the study, they will use what materials and methods you have described, and they should be able to get the same results as you've got. That is called replication of scientific work, and it is a very important aspect of research. So if your materials and methods has not got the sufficient detail, that's not done. Means that that's something that we need to work on. So for the materials and methods, the verb tense is simple past. We did like this, we did like that, and so on. Whereas when you write the proposal, it's about present. Materials methods typically are around 800 to 1,000 words. And if you're doing a clinical trial or an intervention study, you need to quote at this stage your trial registry number. If you don't have a trial registry number, then it will not get through in any of the journals that are high impact journals. It is mandatory that you have a clinical trial registry number for an intervention study. Be aware of this. Regulatory requirement about ethics committee approval and so on should be mentioned in this stage. And without this, most of the good journals will not even accept. You need to have a clear-cut ethics approval. I also know of some journals which insist on sending a copy of ethics approval. So please be aware that things are becoming much more stringent than what they were a couple of decades back. Moving on to the results. Results have to be described the way they are. You have to be very clear about how you are going to talk about the statistical measures. Linking to the table is very important, figures as well, and the verb tense is simple past. What not to do in results? You kind of reduce the text, okay? You don't go on describing every aspect of results, like baseline variable, we saw so many and so on and so forth. Just mention if the baseline variables were identical, similar, you just mention most of the baseline variables were similar, no significant difference, and link to the table. So if the reader is interested, he or she can go to the table rather than going through the whole text. And also have consistent and uniform manner of describing the results. So what I mean by that is, like, I'm just showing you one of our articles. You can see the way we have described the outcome, like the low birth weight. The way it has come, it's all so uniform, okay? Adjusted odds ratio of 0.95, confidence interval of so and so. We've not changed any of the pattern, the format that was required. What happens typically is people start using one particular way of describing results in one paragraph and they switch to another one in the another paragraph. This is something which has to be totally avoided. There has to be uniformity and consistency when you describe the results. Okay. Coming to discussion, summarize your findings. So the first paragraph of discussion is all about summarizing what you found. So the current study found that preterm risk and low birth weight was higher with, let's say, autologous or fresh embryo transfer compared to the frozen embryo transfer. And a couple of more lines, that's all it is. Summarizing your main finding and the side findings, whatever the ancillary findings were, you can summarize and stop there. The next paragraph immediately shifts to all the studies which you had introduced or you had mentioned in the introduction. Those landmark studies or the primary references will be opened up in the discussion. You will go and explain the findings of those studies and compare with your study. If they were in agreement, you will say so. If they were in disagreement, you will write the reason why you feel that your study findings did not agree with the previous study finding and be reasonable in that. Okay, that's the second paragraph. The third paragraph is all about limitations and strong points. That means that you are going to tell about your strong points, of course, but you'll also tell limitations. Remember that all the studies will have limitations. Conclusion will be the last paragraph. It's about highlighting your new findings, but also telling that, listen, we've not got all the answers. There needs to be future studies, and you can tell what kind of studies you want and what area. Okay, this is where you're going to tell. So there is implication for practice and implication for research. So what not to do in discussion? Again, vague and exhaustive discussion, right? Everything under the sun. That's not something that is really I'm looking forward to as a peer reviewer. Just be specific. 4 or 5 paragraphs. One is summarizing. Second is discussing studies, discussing the reason for disagreement, telling about limitation and strong point about your studies. Fourth is the conclusion. That's about it. And also, if you don't discuss the appropriate studies or not give reasons for why your study did not find the same thing as the earlier one, that is something that to be avoided. But be upfront in telling what are the limitations, what all you could not do, why the outcomes were not followed up. What were the limitations you faced? Why did the study get prolonged? There's so many things you can have. So those are something that is required. It should not happen that somebody else points out that you have so many limitations. If you upfront identify that, it's a good thing. Conclusions, aim and conclusion should match. Okay. What happens frequently, what I see in our part of the world, our articles extrapolate. They plan for study for a subgroup of patients and then they extrapolate to the rest of the population, which is something which is not done. So if you have a study in PCOS women, you will extrapolate the findings to all the women with ovulatory dysfunction. That's not done. You cannot extrapolate. Answers should be just what the aim was. So if I just gave this example yesterday, again I'm giving. If the PICO statement was yesterday was for this RCT was woman undergoing IVF without PCOS, freeze-all versus fresh, ongoing pregnancy. This is an NEGM article by Lan, Professor Lan from Vietnam. Answer conclusion, just see the conclusion. It's one sentence. Among infertile women with PCOS, without PCOS who underwent IVF, transfer of frozen embryo did not result in higher pregnancy rate or live birth rate than the fresh. She did not say go do freezing only or don't do freezing. That is not our job. We do not recommend. Many people tend to start adding recommendations in conclusion. That is not what our job is. Our job is to just state what the facts are, okay, of what all the findings are. It's for the reader to decide, or the guideline makers or the policy makers to take it forward. It's not the job of the article or the paper that you're writing. Which journal? I think this whole topic has been dealt by Priya yesterday, so I won't go into detail. Be aware of the top journals in your specialty. So there's like for obstetric and gynae, there's some good journals. Like right now, fertility sterility is the topmost journal. This is 2013 impact factor as a specialty. Like for us, it's human reproduction update has the topmost impact factor in OBGYN. It has around 13. Whereas fertility sterility, human reproduction update only publishes systematic reviews. Fertility sterility and human reproduction are the other top ones. But when you go beyond the specialty, like the medicine journals, it's Lancet, it's JAMA, it's NEGM, and so on. They have an impact factor which keeps changing every year, 45, 50, 70, 80, and things like that. So if your work is groundbreaking, it will make it there. Probably that's the way we go. Also, I think I'm not going to go detail on journal requirements, but when you have finished your study and you've written up the stuff, spend some time in formatting and referencing. There are a lot of software to help for referencing this. I think Priya has explained yesterday, so I won't go into detail, but do that in a very meticulous manner. Some of the journals will keep on sending it back to you if you don't do this. Okay, it takes time. It's painstaking and time consuming. So probably it will take one of your weekends even after finishing the writing of the paper. Do a good language and grammar check. See, I do this very regularly. If we have some issues about, we're not very sure about, grammar or language and all, we can always ask help. Even softwares are available for grammar check, spell check, everything. So you are all youngsters, you know everything. It's all there on the software or there on the internet. Other good advice I would give here is about making a third person read your article. Does that person make sense of it the way it's been written, whether it's conveyed or not? It's a good practice. It will help you make it look better. Authorship. This is the ICJME MJE guidelines. So all three have to be met to become an author. That means you should be involved in conception and design, drafting, and final approval. Just acquiring data doesn't automatically give you the authorship. Please remember this. Just writing the article does not make you the author. It is a mixture of all three. And it's a good thing. In Indian scenario, I would specially urge everybody to make this a habit, to decide authorship before the project is launched. First author is the lead author and responsible for writing the first draft. Remember that last author is the senior author. Now in India, the culture of senior author is not there. Many people don't know the importance of senior author. That's what I could figure out. So abroad, the senior author is given a lot more weightage, because senior author essentially has guided the postgraduate or the junior faculty or colleague to do the work. So it carries a lot of weight. So it should be something that we should keep in mind. And MCI currently, the latest guideline suggests that you should have either the first, second, or third author to be considered for promotion, or the corresponding author. So it keeps changing. It's changed more than one time in the last decade or so. I would like to take this point about ghost authorship. It's a big issue and we need to address it. Many times it so happens that all the names of the faculty in the department get in as authors, which is something that has to be clearly discouraged. And it is something that we should worry about, because this is not ethical. It's not complying with the regulations, and things are getting more stringent. there is a scope for joint first author. So if you feel that there are two people who have worked equally hard for the project and written up the manuscript, then you can write to the editor and ask for joint first authorship. This is something that is acceptable. Now, there are people who have contributed to the research in some ways, but they don't fulfill the authorship criteria. But then they can definitely be acknowledged, and it's supposed to be a good practice. Declare conflict of interest. These things become big when you start doing a lot of publications and so on. So if you are a stock owner of a pharma company, then you declare it. You have received grants, you declare it, and so on and so forth. Conflict of interest is a big issue. As you grow up in your professional career, you realize that there are a lot of things which get muddled up because of conflict of interest, and it's a big issue across the world. So right now I'm just putting one slide on this, but remember that conflict of interest is a big issue and it has to be declared upfront. Once you are done, you got your folder ready. All these things are required. Covering letter, title page. Title page is all about describing the authors and their affiliations and so on and so forth. Then the manuscript. COI is conflict of interest. Tables are separate, figures, checklist for all the designs that have been taught to you yesterday also. Like every form of article requires a checklist, be it a randomized trial, be it be a cohort study, be it be a systematic review. Once you've done, you submit, and hopefully once the editorial check is done, it goes to peer review, and we pray. We pray that there's favorable reports and so on, but then many times what will happen? It will get rejected. So what happens now? I have covered most of how you prepare a paper and submit it. Okay, now we also face a lot of rejections. So I thought I'll put some slides on how you face rejections. So every time over a week when I get rejections for our work, initial reaction is about disappointment, frustration, little anger. Then we start blaming everybody across the world in our minds. But I'll be frank with you, sometimes I expect rejections and sometimes it's unexpected. Because the good principle of submission is that what I do is I strongly encourage everybody is to put their research work in a high impact journal or whatever you want to aim one level above that. Okay. So sometimes these journals reject it, but they give good constructive comments. So that will help you improve your manuscript. Okay. So rejection is fairly common. So all of you postgraduates, I want to tell that getting rejected is not something to be, afraid of. It is a part and parcel of scientific peer review system. Most of the published articles would have faced rejection in some other journal. I can tell you that with some confidence. Happens to all the established investigators. This is something that I can tell, and we should feel, this is a part and parcel of life. So nothing to worry on this. I'll just state some of the reasons for possible rejection. Most of it is sometimes we end up submitting an article in a journal which is not looking at that kind of article at all. So that's the scope of journal. So spend some time on the journal website to see if it's in the scope. Second is that topic is no longer relevant. This happens very often to us. What we think is very important to us may not be of interest to rest of the world. And this is something that we need to understand. So if the priority is low, it will not even get selected for peer review. Nothing novel, you've just done something which was already known. This is again something I stressed yesterday. Poor methodology. The science is not correct. It will get rejected. They will not even look at it. Very small sample size, 50, 100, 200, 300, doesn't ring a bell. Many times if you have very small sample size, it will get rejected upfront. Flawed methodology. It's something more like poor methodology, I would say. And the last one is also something that we need to improve on. Poor grammar and presentation. The way we submit the paper itself puts off the reviewer. The editorial board feels, okay, this is really badly packaged. It's not even worth considering. There could be some element of bias in this, but then yes, it is something that even I find as an editor annoying. Okay, because I have to understand that the editors and peer reviewers are doing a job. It is a thankless job. They're sitting in the evening hours in their family time and trying to review your work. So they should feel interested. So it's about capturing their interest. So if you don't put that effort, they are not going to really go after you and try to make things work. Okay, so they are going to reject it at the first instance itself. So be aware of this kind of dynamics in peer review system. Suppose it gets rejected and there's an obvious methodological flaw, then nothing much that we can do. If you find that there were some constructive comments and you can reanalyze the data and or add an additional analysis, it can probably salvage the project. This is one of our papers which was rejected 6 times, but finally it got published in the Asia Pacific Japanese OBGYN journal, and it was a good one. So it does face rejection. Couple of words of caution to the youngsters. Okay, there is a big market now for predatory journals, which are essentially open access journals which pay fees and you can get your articles published. The main mechanism is there's hardly any peer review system in place, and the NCI has blacklisted and keeps on updating this blacklisted list. And if you publish in these kind of journals, it is taken as a black mark on your CV. So be very aware of these things. Like for our institution, our library has this list all the time. It gets updated. So if you are publishing in these predatory journals and putting on the Facebook, you're going to get in trouble. Okay, because this is not something that anybody, an academician, will like it. So predatory journal is something that you all have to be careful about and find ways to avoid. Practical tips: start with simple case reports. That's a good start. You can always do that. And when you face rejection or just when you start submitting, you'll get peer review comments. They are learned people who comment, and it's a learning experience. Like I have learned a lot over the last 15 years just by going through the peer review comments, because that's again a part of learning. Also, I would strongly suggest, if you feel not confident about the paper language, the way it's been written, ask for help from colleagues. Okay, take them for a party or a dinner or so on and so forth, but find ways to get help. Okay, I do that. It's something that, it has to be a man management, resourcefulness, I would say. Couple of warnings. We are facing a lot of problem in terms of fraudulent data, and in our specialty in reproductive medicine, now this has become a big news, buzz news. Fabrication of data, plagiarism, duplication of data, which is a strict no-no. If you are caught, it can put a big full stop for your academic career for good. Clinical career might go on, but academic career is shut. So there are people who keep a watch on these papers, and now, I can tell you, last month there were some whole lot of randomized trials which were retracted in fertility sterility. There were trials which were dealing with very common topics, and they were retracted. This is just an example of one more paper which was retracted. My take-home message to youngsters is, the first thing is, have a good project. If you have a good project, then only you will have a good paper. You can't have a poorly done project and a good paper. It doesn't match. So a good data is a good start. Writing a paper requires a lot of time and effort, okay? And help from seniors who are willing to help will be an asset. I think perseverance is the key. People expect things to change in a couple of years or 3-4 years. It doesn't happen like that. It will take multiple projects, multiple publications to learn the nuances of publication itself. It takes so much of time. So, but then, academics and research is a long innings. Okay, it's not a short inning like 2-3 years and done with it. You kind of become better and better with each passing year as you continue doing the work. That's how it is. I would stop the talk here. I think we've done. I will be happy to take any questions that are there.
Thank you so much, Dr. Mohan. I think it was a wonderful elaboration. And we have one question from Dr. Chandni from Kangra, and she's asking that which type of topic should we write and whether it should be a rare, unique topic.
See, if you have a rare case thing that you have encountered, then it should be rare for everybody and it should not be rare for us. In the sense, we find some of the very rare cases once in a while on a career, professional career, but that doesn't mean that case is rare. So if it's really rare, like you go do a literature search and find out hardly any few case reports reported for that condition, then you can write it up. That is something that's what. But otherwise, what happens? Somebody feels they have seen this for the first time and it becomes rare. That's why. That's not the way it is. So I would encourage, if they really feel something has happened which is not seen very often in the literature, then they should try to publish it. That would be a good start. Yeah.
Also, sir, like if I am like a new PG and it's my first article which I'm planning to publish, what do you think I should write about? Whether should I go for a case report or should I go for my thesis? Where should I start from?
I think starting immediately would be difficult because you are still learning the subject itself. I would say that all PGs, all the guides and teachers should ensure that their PGs finish the thesis and publish it. Okay, while they are looking at the PG thesis and getting published, they can always do couple of one or two case reports during their career, the PG time. To start with, and by the time they finish their thesis, they should be start writing it up, because most of your writing thesis is much more lengthier than writing a paper. You just have to take that part and edit it and put it as a paper. So that's all you can achieve in that 2-3 years of post graduation, but you can build on it later. Yeah.
But incidentally, case reports are not accepted any longer. People don't feel happy receiving case reports. So,
yeah, ma'am, that's
so the cutoff is, they ask you if it is case series, then at least they give it some consideration. Otherwise, it's completely. So there are specialized, special journals which dedicate only now to case reports.
Yeah.
So it's a good idea to look at them, because there the negative responses one has to be ready for.
It will be used by rejection by that time.
Yeah,
because you learn to accept rejection.
Part and parcel of
start somewhere, you'll finish somewhere probably better.
I have a few more questions. Dhrumil Patil from Vadodara is asking, sir, are all the journals who ask for fees open access journals? Like BMG has extraordinary fees by high impact factor. I am very confused about it.
No, the thing is, all open access journals are going to ask a fees. But predatory journals are all open access, but all open access journals are not predatory. Okay, so like Lancet and many of these journals like NEJM are all like you can access them, but they are not predatory by any stretch. Okay, but the other ones, there are like, I can tell you that our side of the world and other continent, there are like from one office, some 300 journals were launched. Okay, predatory journals. So now most of us who are into publication know our emails are bombarded every day for a last minute submission in their journal for some fees and so on. So my caution to all the youngsters is don't fall prey to this thing, and you should be careful about going for a predatory journal. Yeah.
So can I republish a rare case report in an index journal after publishing it in a smaller journal?
No, there is nothing called small and big journal. So what I would suggest is once it's published already in a journal, it's not correct to republish the same work. Yeah. Yeah.
So one more question. How many authors do you think are okay for an article? Like sometimes you see an article and you see there are lines of authors in it. So how many are okay? Like,
now, normally for each journal, they will specify for an original article, let's say 6 or something. But then this is not sacrosanct in the sense that there are multi-center collaborative studies, means that each center will have an authorship. That means that let's say some 20 units were clubbed in for a multi-center trial, they will have authorship and probably they will have equal authorship for all of them. So that's nothing sacrosanct about that number.
So in fact, today you can even have the option of having group authors. Yeah. And if you were to look at the genetic journals, they run up to 150 names. You just have a look at the NIH site. So things have changed.
Yeah.
The last question, like you were talking about sample size, that most journals will not look at a sample below 200 or 100. But
that was just an example. Yeah. Yeah.
But sometimes we see like newer modalities are coming in, new drugs, and we have very small sample size. So
yeah, so that depends on, like, that was just a general statement, though there is no particular cutoff for a sample. It's just that when there are bigger, already studies are done and established things, and then you have very small sample size coming out from our studies, they will not take it forward. But for a very new, novel method, there is something called pilot projects and pilot studies, which might just be like 30, 40. And that is fine. You can't have big sample size for that. So it all depends upon the question. What I'm trying to say here is most of our studies which get rejected are mainly because of very low number of sample size. This was something that I elaborated yesterday also about, like, let's say perinatal outcomes in IVF. All the Scandinavian countries and UK and so on have a database of 2 lakh, 3 lakh and 5 lakhs. And in that, when we come up with one center, you might cobble up 1,000, 2,000 babies. But that is no match for this kind of data. So we will not stand a chance.
Yes. So Kishore Kharel is asking that can we publish our thesis in parts like we have a primary and secondary outcome?
See, that is a tricky one. It's there. We should be careful of something called salami slicing. So if it has been upward decided, like you have finished a part and then you take another kind of approach where you write follow-up. Let's say I was stopping at live birth and now I want to see how the babies did 1 year later, the same babies. Then it can be a separate publication. But you can't write, okay, one study was only till clinical pregnancy, then I will write the live birth of that study and so on. That is called salami slicing. That is something to be avoided.
Dr. Radha is asking, I'm a faculty in an academic institution and there are many journals asking to be a reviewer. How to choose?
That she has to do the background check of that particular journal, how good it is in terms of the work that they are publishing. And if they feel that one particular one which is the best among the lot, it is a good thing. Like I myself learn a lot when I peer review. I also ask for the editor to send me the comments of the other peer reviewer. So that's how I compare whether I did the right thing or I caught the things correctly or my fellow peer reviewer has done that. So it's all a learning in all the aspects of publication.
Dr. Shrikala is asking that I have done a poster on a rare case in a national conference. Can I publish that case in a journal?
Yes, definitely. A poster is not considered like a publication. Like all of us present in Esri, it gets a publication as an abstract. That's not considered a publication for anything. You will present that and then you can publish it in a journal as an original article. Yes.
So thank you so much, Dr. Mohan.
There's one question from Jayam Kannan madam actually.
Yes. Please.
She's logged in for this. She's saying it's a very nice talk. I would like to know whether PGs, the PGs are asked to finish the thesis in the first year. Your idea, please.
Ma'am, PG, first year only they should finish.
Finish the thesis. That's what they've been told to do it actually. Like finish the thesis in the first year itself.
That will be a little challenging. I would say for a 3-year course, if they finish by the second year, we still have time for publication. And that is why, like Dr. Radhika madam, we have discussed this, like we should focus more on observational studies, which they can, instead of doing all intervention all the time and prolonging the time period. And they also get stressed out, because they have to go and follow up the cases, recruit them and so on. So if we are really keen, we can look at observational studies, especially retrospective, and make them finish in the second year. That is something we can achieve.
And there's a question from Dr. Sasireka, and she's asking, can we get guidance from the legends in this forum for their studies? Will you be able to guide them?
We all have, we would like to as much as possible in whichever way we can. Only thing, we are also humans. That the problem is end of the day, the time, because it's not easy for us to connect for each project. See, superficially, it's not going to work out. At some point, when somebody sends a project, we have to understand what they are trying to do. So all this is about, we will definitely do something. I think Ashwath and all can take it platform helping out youngsters. And
yes, we will do it, Mohan. We will, with all your help, faculty will make a big team, and not that everything will be sent to one person. I am also planning at the end of this thing, we will make a big team for the postgraduates and then guide them. So we cannot guide them for them. It will be done, Mohan. Definitely.
I have a comment. Actually, they would be having their institutional research board. They have their own set of system which is working, So I think it is better to adhere to that system, because ultimately hand-holding and passing of their project will be done by those people.
Madam, that is correct. But we will just guide because of you all are so experts in this field, just see that and okay, there's some problem in this study. So for example, one paper is being rejected. So that student wants to know, maybe I am the professor, but I don't have that much experience in publishing. So that student sends a mail to you or in a team. We make a team, sends a mail to, can you help that student? Okay, you have to read, like Dr. Mohan told, you have to rewrite the study, or you have to something. You can do it and send it. It may be beneficial. That type of advice, not that complete doing it for it.
So we are getting few more questions. Dr. Tamna is asking that, is there a time limit within which a thesis is likely to be published?
No, there's no time limit. See, just the project is done. it's usually what will happen once the PG is finished and go off, then it's going to be difficult. So it's all about how the postgraduate is going to, how responsible that person is and takes it, they will help out and finish. See, guides can't go after them to go on finishing it. So I would say if the person is really up for it, then that relation, even once the data is done, it's just about following up. Everything can be done on email, So
and earlier the better. Before
the better. Yeah, it should
before it
become
becomes.
Yeah.
What is like the sample size looking for awareness prevalence in a particular population, like regarding a drug or a procedure? Dr. Vijay Lakshmi is asking.
The sample size calculation is all about the specific question that is asked. So it's difficult that we can't say that a specific question is given, then according to the background data, it has to be calculated. Yeah.
Dr. Himani is asking, do we have any word limit for a manuscript?
No, that each journal will put that. Original articles is like 4,000, 4,500, like a systematic review is 5,000 to 6,000. Case report is less and all. So they'll have to see which journal they are going for, and then they will refine it and edit it accordingly.
Dr. Pratyusha is asking, what are the specifications for making an
That's Dr. Radhika's call.
Radhika, you can answer.
What is that?
What are the specifications for making an e-poster for any PG online conference?
October 10th conference.
That we will put the
inside information.
Today we are having a meeting to so we will be getting inputs from Radhika madam today itself, what to plan for that e-posters. So
very smart, very smart.
For this again.
So the specifications will be given wherever she is planning to post her thing. So there will be specifications and she can accordingly follow the instructions.
There's one comment by Dr. Jayam Kannan Madam to Dr. Mohan Kamath, and she's saying that it's nice to know that there's a need for perseverance, persistence, and then perfection.
Yeah.
That's a comment from me.
Thank you. Thank you, ma'am.
Thank you, Dr. Mohan, and we can now go forward for our next lecture. And I think after learning about how to write a paper, a poster, and an article, one of the most important things comes to us is the ethical and legal aspects, and we have none other than Dr. Meena Samant for this. She is one of the senior consultants in an HOD of Khurji Holy Family Hospital in Patna. She is also the chairperson of Foxy Clinical Research Committee 2019 to 2021. She is the Secretary General of ISOPAR. She has been the Vice President of Patna OBGYN Society, Secretary of Patna OBGYN Society, and also has won many awards and has published many papers. Welcome, Dr. Meena ma'am, and I'm sure we are going to have a great lecture from you.
Meena madam, start sharing your...
So good evening, everyone. Thank you, Niharika, for those kind words. Let me share. I know I'm going to talk on a topic which has been partly covered by all the speakers.
But it is the most important topic of the day.
Yeah. I would say once you go on with your research, this is the first thing that you have to do. But I'm going to present it towards the end of our series. So that is ethical and legal aspect, obtaining ethics committee approval. Okay, just a second. So thank you, Dr. Alpesh, Dr. Ashwath, Charmila, all the organizers for giving me this opportunity to present this paper here in this forum. Now, ethical approval should not be treated as a chore or a hoop through which researchers must jump before they can begin their research. So what is ethics in research and why is it important to get an ethics approval? Basically, ethics is knowing between what you have right to do and what is right to do. That is according to Stewart. And medical research is a branch of medicine that determines the safety and effectiveness of whatever you're trying to research, the medications, devices, diagnostic products, treatment regimens intended for the good of the human use. And in clinical practice, established treatments are used, while in clinical research, evidence is being generated to establish what is the best. Now, basic idea of ethics in research is to create an environment in which an individual is treated with respect, tolerance, irrespective of age, sexual preferences, race, disability, disease, religion, social status, on the principle of autonomy, beneficence, non-maleficence, and justice. These are the four things that are the underlying principles of ethics. So there are other dimensions of ethics in research, and I will just skip because our talk is dedicated to the young researchers, the PGs. So because your ethic approval has to go through an ethical committee, so what is this committee? What constitutes this committee? And what are the responsibilities of the committee? Let's have a look at that. Now, here we call it the Institute Ethical Committee. Research Ethics Committee must include individuals with scientific and medical expertise. So if we have a topic in infertility, we would definitely have in the committee those experts who are dealing in that subject. Then some type of risk and benefit may be more easily identified by non-scientific members, particularly those related to social, legal, or cultural considerations. So a third person who is not actually medicine person would also be there in this committee. Once risk and benefit has been identified, determining whether the relationship between them is reasonable, whether it requires value judgments as well as scientific analysis that is going to be looked at. So a diversity of backgrounds and qualifications in medicine as well as law, social science, etc., even a religious person, they all can help to ensure that these judgments are not inappropriately dominated by a single perspective. So a holistic approach is what we're looking at. Social diversity and gender balance. So we have to have both male and females in our committee. So taking account of all these given criteria, an ethical committee will constitute almost 7 or more persons. We know WHO, which is so stringent, they have about 27 members in their committee. So what is the responsibility of this committee? They are going to look, does the study have real or potential individual or community benefit? Does the potential benefit far outweighs the risk associated with research to the research participants? Will the participants and communities have access to the study findings and benefits of the research? What is the mechanism for provision of safety, care, and support to the research participants? Now, coming to the big question, how to get the ethic committee's approval? Now, if you are a PG resident and have been assigned your thesis work, then it may be the very first time in your life that you're doing a research. You may be clueless, confused, skeptical, so many emotions at the same time. We've all gone through that. So it's time to talk to your senior resident. They would be more approachable. Have an idea like where is the ethical committee? Where is the clerical section? How many members are there? Do they have any preferences? Does the committee have a pre-designed pro forma and so on? So most of the institutions have a checklist of research proposal submission. And if not, they may have a fixed guidelines and certain criteria. Collect the checklist or whatever is available and try to understand. Consult your seniors, batchmates, even the batchmates in other departments, or even the Google. So these are some examples which show the checklist. Now confirm the date of the ethical committee meeting, because this is not the last night, affair. A completely filled application form must be ready in advance. If your institution asks for a presentation prior to submission of the application, prepare it carefully. Your presentation must incorporate the scientific and social aspect of your research subject. You should talk about the patient's benefit, cost effectiveness, no harms, and not putting extra physical or mental burden on the patients. Now, if your institution demands that application should be submitted beforehand, be punctual, submit it, and start reading. You should be well aware of your research subject. how you're going to collect your data, the methodology, and how you're going to planning to come to a conclusion. The bottom line is you should have a clear understanding of your research and you have to, because you have to make them understand, the committee people. So you write up your proposal in a clear and crisp manner. We've already heard about the preparation of a presentation, the font size, characters, they should be appropriate. Reference writing should follow a single and standard style, and Vancouver is mostly what is used. Objective of the study should not have a long list, if required, divided into primary and secondary. Method of the research should be written in detail, as this is the area which is going to get scrutinized most. Every single step should be described in detail and in simple language. Your tool of data collection and storage, as well as processing, should be mentioned in the proposal itself. Now, prior to ethical review, it is a scientific review of the research proposal, and it explores the scientific novelty, rationality, and the relevance of the proposal. This topic too has been spoken of in detail. The topic that you're going to choose, how it has to match with your study design. So it explores soundness of the study design, like the sample size, criteria for inclusion and exclusion, randomization technique, blinding, procedure pharmacy plans, the endpoint assessment, etc. So idea behind this is scientifically well-planned studies are more likely to be correctly address human subjects and ethical issues, and more likely to be approved. So exactly what it is looking for, a clear concept and understanding of the research subjective, why your research subject is important, and what positive change it is going to bring to the fraternity and society, competence of researchers and the research team, cost effectiveness of your study for both the patient and the institute. Also, the provision of protection of human rights, the confidentiality, and non-discriminatory practices, and a proper informed consent, reporting and managing of adverse effects, if any, and post-research care and support, reimbursement and compensation. So informed consent is an integral part of the medical research, and research proposal must have one architected informed consent. I've not gone into the history, but as you all know, this all came up after the Holocaust of 1940s, and then then so many reforms have come, the Belmont, after the Helsinki, then the Belmont, and so on. Our own country had its ethical research, came up in 2000, and that too has undergone certain revisions since then. And all this because in the name of research, many atrocities were being done. And while we are so well-informed doctors, and yet in the name of science, and also our moral and ethical values change over time. So informed consent is a process of getting permission before constructing a healthcare intervention on a person or for disclosing personal information. Seeking consent is fundamental to research involved people. That is, autonomy of the patient is paramount. So forms should be written in a prospective participant's mother tongue. And when this is not English, the English language translation should be provided as well. Now, if they do not, if they may not be very literate, then it could be an audio one, a third person approval. These two methods can also be used if patient has limited understanding, provided this person should not be associated with the ongoing research. That means an independent person. The consent form itself has two parts: an information sheet describing the research and the nature of participants' involvement in it, and a certificate of consent attesting to the patient's consent. So both parts should be written in sufficiently large letters and in simple language, which is understood by the patient, so that the participant can easily read and understand the contents. So the information should be written in third person. Example, where you would be meet with the researcher, so on, whereas certificate of consent should be written in first person. I have been informed that so and so this is going to be done. So medical terminology should be avoided in writing up the informed consent form. And the information sheet also, it has to explain the aims and objectives, the methods, confirmation that the ethics committee has approved the project, the legal right and the safeguards provided for the patients, and the project involved, if it involves randomization, the nature of the process and reasons for it must be clarified. Information about possible benefits and risks, advice that they can withdraw anytime, and the assurance that if they withdraw, this will not adversely affect their relationship with the care provider. An explanation of how personal information will be stored, transmitted, and published. The information, what information will be available to the participants about the outcome of the research. So if there are any adverse events, then arrangements for responding to those, and details of the compensation available should the participants suffer harm as a result of their research. So both in English and Hindi, these are the two parts of the consent form that I have tried to show. So this part has been, dealt with. Just to briefly highlight, any bias, inappropriate, you have to avoid all these. Any bias, inappropriate research methodology, incorrect reporting, and inappropriate use of information. There can be fraud in research and publication regarding the data. It can be data invention, which is called as the fabrication, or data manipulation, falsification. These two can affect the research in a very bad way. Sometimes, what the students would do, okay, they're not getting, they think that this is the right thing. Everybody is getting this result. Why this study is not, let me change some of the data, but that is not to be done. In fact, he may be right. The other studies may have some other biases. Other is the plagiarism. It is basically others published and unpublished ideas or work without permission or attribution to their credit, and presenting them as a new or original rather than informing the source. So we just heard about it. Then there's also publication overlapping. It's called overlapping. If we publish same study in two different places without any information, duplicate or redundant publication, or even the salami publication was Dr. Kamath was just mentioning, alluding to. A same study being divided into a number of pieces, slices, and presenting as a new. So that should be avoided. Then if we slice or extract data from already published study, that is not accepted. So ghostwriting, when the writer is not given credit for his or her work, and authorship conflicts, decide the authorship credits while writing the proposal. It brings clarity regarding the responsibilities. Now, this is the website, ctri.nic.in. This web address is the online registry system address in India. It acts as a free and online public record system of clinical trials conducted in India. Now, the Drug Controller General of India, the DCGI, has made registration of any trial conducted in India mandatory since 2009. It is an important step towards better reporting and improved legal aspect for publication of our research work. So why do we register in this? Because it is mandatory. After complete registration, they issue a number, which is called the DOI, Digital Object Identification Number, which you will require while submitting your study to a reputed publication house. So what to register? Any clinical trial conducted in India, if it involves human participation. It can be randomized or not, or any drug, even if it is already available in market, preventive measures, lifestyle modifications, any device. Educational behavioral rehabilitation strategy, even if it is associated with yoga or Ayurveda, then you need to register. So better to register if you're confused that it should or it should not be. So postgraduates have a dedicated section for their thesis registration, as you will also need to publish your work in future. So when to register? Before you enroll the first participant in your research, that is the best time to register. The principal investigator has to register. A principal investigator in a postgraduate thesis is the senior guide. First, you have to get a letter of approval from the ethics committee. Ethics committee will be registered to the should be registered to the DCGI or ICMR. Now, each institute may have their own ethical committee, but for publication, you would need it to be registered with the ICMR. And if it is a drug trial, if drugs are being tested, then DCGI must come in. Now, what I was looking at our own hospital ethical committee. So now the DNB would require your ethical committee to be registered with both, because you do not know which candidate would like to go. So it is better to register with both. So follow the user-friendly steps to register. So the new drug and clinical trial rules of 2019 notified to the Ministry of Health and Family Welfare, whether in public or private, and who are conducting or intending to conduct biomedical and health research involving human participants are required to register their ethical committee. The registration portal will be carried out online in the Department of Health Research via this portal. So now again, going to the authorship dilemma, it has been addressed just briefly. International Committee for Medical Journal Editors has these 4 recommendations: substantial contribution to the conception or design of the work, or the acquisition, analysis, or interpretation of data for the work, and drafting the work or revising it critically for important intellectual content, and final approval of the version to be published, and agreement to be accountable for all aspects of work in ensuring that questions related to the accuracy or integrity of any part of the work are appropriately investigated and resolved. So a good research should be well justified, properly planned, appropriately designed, scientifically valid, and to conduct a research to a lower standard may itself constitute misconduct. So with that brief presentation, I come to an end, and relativity applies to physics, not to ethics. That's what Albert Einstein said. So thank you.
Thank you so much, ma'am.
Okay, another thing, just a second, Dr. Niharika. During this time, many doctors have approached regarding the ethical committee, because there are many people in private who are not associated with an institute who have the ethical committee, and they do want to do research. They have no dearth of data and they want to present their work. So how to go about it? So as the committee chairperson, I had discussed it with the FOXI. But then because it's a very strict, this ethical committee guidelines are so strict. So if there is any, flaw there, fraud there, so the FOXI stands to be, may have some legal issues. So at that level, it was thought that it should not be. FOXI would only support maybe surveys, but not trials. In any place, there would be, medical colleges, teaching institutes who have, I think many of them do not entertain outside research, but some of them do. And some of them do for free as an encouragement, but many of them would charge, and that charge could be significant also. Because as it is for any constitution of ethical committee, a cost is involved. Then we also looked at our own society going in for, creating, but then we found that the cost effectiveness would be there if at least 4 or 5 papers, research works are done in through that ethical committee, in that area or that particular society. So this is something that could be looked at. But I do not know. I find that these days, now that webinar, now we've all become tech savvy. People of the ethical committee, they don't have to travel so much. Can we not have online, ethical committee meetings? That saves a lot of cost. And I think from our side, we could, approach certain bodies who could encourage research and, allow people who are not affiliated to institutions to go ahead and go for ethical committee approval. So thank you.
Thank you so much, ma'am. And we have a few questions which we would like to take. Sasi Rekha is also asking the same, that for a private practitioner, we are not having any institutional guidance.
Yeah, actually, for any research, now you have to go, because otherwise no reputed journal, they would accept it. So you have to go for ethical approval, and that ethical committee should be registered with the ICMR DCGI. So that is what the new. Now with this, the idea should be to encourage research, not to discourage it. So I think now time has come with all these regulations and all. We should be more proactive. We should be, now I think what COVID has taught us, that we can all meet together on this platform, and which would be even, we could make it cost effective for everybody. So if Dr. Shashi Rekha has an institution, they could talk, or I think Foxy could, approach those to make them more friendly towards the private practitioners, our Foxians who are interested in genuine work. But then everybody has to understand that research has a certain, it's not just about collecting a data. It has a series of steps. It has a cycle, and it has to be followed in that particular way, and ensure that no fraudulence is done there. You do not manipulate your data, because these people, they also go and check your work. They go and look at your reports. They go and check your data. And then, it would be, like Dr. Kamath and Dr. Radhika pointed out, you lose your academic career and if you do any fraudulent there.
Thank you, ma'am. And Dr. Vijay Lakshmi is asking that, is ORCID ID mandatory to submit a study for publication?
I do not know about that, but what I mentioned here about the DOI, that is what you have to do. Yeah, please, Dr. Rai. Yeah, Dr. Rai.
ORCID is basically it's a place where you register, and that has your entire publication, or it completely follows your publication process. So it is by choice, by ORCID linking to your publication, it gets added on. There is the public is able to view, and it adds on to your total number of publications that you have done. So it is not mandatory, but it is a good idea for all the authors to register and have an ORCID number.
Thank you, ma'am. And Dr. Saraswati is asking that, do we need ethical clearance before publishing a case report?
Any publication, for any publication, you do need. They will be more generous towards you. They would not be that stringent, I think, but for any...
No, but wherever there is a patient who is involved, it certainly requires, there should be, I think, no doubt in anybody's mind. Yeah. Even if it is a single or whatever, wherever there are human beings, they require ethical clearance.
Dr. Radhika, I am a bit different on that. For publishing a case report, actually you don't require the permission from the ethical board, but of course you need to inform the institute head about the publication of that case report. It's not a data, and in the case report, we are not disclosing the identity of the patient also.
But the point is, actually, we had deep discussions regarding this, not only in our institute, but in other institutes too. The stand is that the patient had come into the institution, and whatever is the details of the patient. It belongs to the institution. So whether the institution would like to share the data, that is their this thing. Now, whether it is ethical or is it, you take a permission just like that, some sort of a endorsement from the institution is required that you can go ahead and publish.
Yes, just the information is required, but the permission is not required actually.
Okay, so in our institution, we need to go through the IC. But the point to be understood is some administrator has to endorse that you can go ahead and publish. You need some representative from your institution to give you the permission. So be it the information to administrator or IC, it could be the institutional policy as the case may be.
Thank you, ma'am. And I think we are done with all the questions. Dr. Ashwath?
Thank you. Thank you. Going to brief, all of you be there for 1 or 2 minutes, just to give you vote of thanks. First of all, 2-3 questions. Okay.
Dr. Sarita madam. She's joined back, no?
Yeah.
Ma'am, Sarita ma'am, there were two.
I'm sorry, I was in another meeting with Dr. Alpesh only, so I just skipped in between.
There are 2 questions left, ma'am. That there's Dr. Indra Bhati from Jodhpur. She's asking, like, can the indoor records be provided to investigators from other institutes for research?
No, you can't provide that until unless you can't provide the institute's research papers to others. Even for the study, if at all they want, and they have to give a written this requisition, and that is the institute has responsibility whether they want to share the data of that institute or not, because that is the institute's confidential record. And such cases, I think the permission of the patient will also be required if at all you want to give it to the other institute.
And there's one question from Dr. Rupa from Tirunelveli, and she's asking, how can we keep the records legally safe?
What exactly I could not understand legally safe, but the thing is that whatever record is kept in the hospital, it is a confidential record. And once the patient is being discharged, all the data are there in the medical record department, and that medical record department is a very strict department where all the data are kept confidentially. And once the record is there in the medical record department, no one can retrieve it without the permission of the institute. So in that way, you are keeping it legally safe. Otherwise, also even in the hospital, when the case record papers are lying on the tables and like that, the ideally it should be kept safe in the cupboard on the safe, so the patient should not be able to access your data. And like in the previous thing, it was discussed with the patient take the photographs and then they can use for the photo and all. So ideally, this should not happen, and that's why the patient bedside tickets are not kept on the bedside. It is in a separate counter, and you have to make the entry once you are back to your counter and writing the notes.
There's one more question from Dr. Devanand from Dehradun, and he's asking, for OP patients, what type of records are kept in the hospital? Usually we hand over to the patient all the OP papers. Is that right?
Yeah, that was one thing before, maybe around 10 years back, we were not using our OP record, but now the system has come, either the prescription as in the computerized prescription, you just make everything noted on the computer and give a printout, and many of the practitioners are doing this also. And then otherwise also, IMA has recommended that you should have a carbon copy of your OP paper also, and that should be duly signed, and the date and time needs to be mentioned, and how long the duration of the prescription has to be very much clear. Otherwise, what happens, the patient can just take out the same prescription and continue with the medicines, and if some comes up with some side effects, then it can be your liability if you're not put the date and the time of your prescription. So I think in my presentation, I clearly mentioned the OP record needs to be kept for 2 years also for the medical legal purpose.
Thank you, ma'am. This question is for Dr. Mohan. I think he has left. So can you take the question, ma'am, Dr. Sarita?
Yeah, if I will be.
Dr. Yarangi from Raipur, and she's asking how to choose a topic for PG research since we have very limited time.
Yeah, that selecting a topic for the research is really, really very important. And that is the feasibility of that topic has to be looked for, whether it is possible to do it in your institute or not. Then the number of cases, whether you'll be able to give the justification to that study. So your power of a study should be good. And then third thing, what has been discussed is the retrospective data is better than the prospective one. And the research timing is not at all a problem for postgraduate, because usually it 18-month time is there for the postgraduates for the research, and the 18 months is usually sufficient time for carry of any of the prospective or the retrospective projects. So the time is not a limit. It depends upon rarity of the cases should not be chosen whenever you're doing the thesis work. So you do the cases where the plenty of number of that cases are there and it is feasible to conduct in your institute.
I think this is for Dr. Ashwath. Dr. Pramila has said, respected sir, kindly consider a retelecast of the class. That
it will be all available. Thank you for the compliment.
Very informative. And since I had to go for duty, I couldn't listen to these talks fully.
Don't worry, everything will be available on the Foxy website within 1 week. So they can see it will be remaining for years in the Foxy website. So they can view again and again and know all these things, and it will be. So let us conclude, Sharmila.
Dr. Ashwath, I just want to mention one question is there, how the private practitioner can do the research, because they don't have their institutional review board, and it is very difficult for them to get the ethical clearance from where they should get it. So I think in the last year managing committee in the Foxy also I mentioned, why can't Foxy ask for their own institutional or like Foxy review board? And then we can have the complete members of the Foxy board for the ethical committee, as we have the subject experts and the NGOs and the judiciary person and the social person. So we can complete the quorum of the ethical committee, and I think this should be taken into the Foxy, where the Foxy can approach to have an ethical board, and then these private practitioners can get the registry and the approval through the ethical board of the Foxy, and the Foxy itself can monitor their progress and the ethical issues in that. So I think we can work on to that to have
in the future. We will work on to it, madam.
Yeah.
So coming to 2 days of excellent deliberations, and more than 1,000 postgraduate benefited from this. I never expected. Actually, so many webinars are going on Saturdays and Sunday, and so many. They have lot of choices nowadays. So 1,000 postgraduates listening 2 days for all these deliberations. It's all because of you, faculty. First of all, I thank Alpesh sir for designing this program and designing this idea. We as PG Forum, we 5 people only executed it. So all the idea came. So I thank sir for his ideas and encouragement. First, Alpesh sir, he is not here. He has been busy with another webinar. That is why I thank from all our side. Then the most important is the faculty themselves. I thank all the faculty for last 2 days. And it was excellent. Today's faculty, Sarita madam, Mohan sir, Radhika madam, Meena madam, everybody, because we have selected the faculty who are the best in the field. So what is it? There is so we are very happy. Students are very happy. They are all, even few teachers are also logged in, as you have seen through this. And another important thing is that we should always thank our supporter academically. Sun Pharma has supported the whole program. So I thank Mr. Anthony, Sapan, and the technical support Kishore for all the unconditional support they have given to us. So always they have supported all the academic activities of Foxy. This is no consultant, is only postgraduates, and also they were happy to support the whole program. I thank on behalf of Foxy, Sun Pharma. And most important is that the audience. Without you, this program would have been nothing. All this faculty, they have gone prepared. They are coming and sharing their knowledge. But without you, and please thank you so much thanks so much because COVID duty, and you are so busy, we know. In my hospital, I thank my postgraduate because the whole COVID, we are all go once in a while, go there, put only for delivery, cesarean, and just go there, give them instructions. But all the patients are looked after by the postgraduates. It's the same all over India. So the hard work they are doing, in between, they have logged in and listened to the lectures. And I am sure that it will be useful for you, especially who have joined in the first year, for them to how to select a thesis, and the final year how to publish their thesis. So it is a complete mix-up of ideas, and we will be, there's so many requests to continue this program. So we will be coming up with newer topics. Radhika madam, Priya madam, everybody suggested different topics. So we will discuss, we will have this forum going like this, and we will have every 3 months or 6 months, we will repeat these programs so that the students will be beneficial. Once again, thank you all before taking a leave. Thank you once again for all the support, faculty, students, everybody. And I enjoyed with the 2 days, enjoyed with all faculty. You are all very good, excellent. And my colleagues, nothing to thank them. We conducted the program. Charmila, Niharika, Shashwat and Rohan, we conducted the program. So there is nothing to thank each other. But officially, I thank each other for the program with the help which they have done. So we hope all the postgraduates, now we have listened to all, especially today, Radhika madam is told how to present a poster and paper. Now let us see you are doing in the correct way. We will monitor you on October 10th. So I encourage everybody to send papers, but we will be having a committee which will decide. We cannot have 1,000 paper presentation on that day. So poster, we can have how many we want. We will put every poster, but there will be some quality restriction to the paper. At least we are planning to have at least 100 presentations for that full day. So let us see in 2-3 halls. Let us see, and rest of the people will be given chance to present as a poster. Even if they are rejected in a paper, they will be given chance to present as a poster. So hope all the best for all the postgraduates for everything, and thank you all once again. Thank you. Thank you so much.
Congratulations.
All of you, thank you so much.
Thank you so much.
Thank you so much, Dr. Ashwath. The great job. Niharika, hello. You did the great moderation. And Dr. Charmila also, I'm so happy you kept my question preserved and I was able to answer at the end.
Thank you. Thank you, ma'am. Thank you for a wonderful session.
I think
Thank
the
you,
PGs
sir.
are leaving, but I just want to add on to the PGs dedication what Dr. Ashwath was telling. Yesterday, only one of my PG just fainted in the COVID ward. I said, you just finish off your duty. I'm posting the next PG over there. She just requested me the evening, madam, I'm all fine. I just want to continue with my duty. Madam, please don't take me out from the COVID duties. So that is the wonderful dedication I have seen in the PG. I don't know how much courage they have got in this way. So thanks to all postgraduate being so good in doing the COVID duties. And we are the consultant just sitting most of the time, not even touching the patients. Our PGs are really doing wonderful job. So congratulations and keep it up, all postgraduates. And you are going to definitely do wonders after this research workshop in your publications and the posters also.
Thank you, ma'am. Thank you for
Thank you.
Thank you.
Thank you, everybody. Thank you.
Thank you.
Thank you. Sarpan, thank you. We will be leaving.
Yeah, it's all our pleasure, sir, and thank you very much for the great